Good morning, one and all. I'm Krishna, and with me I have Apurva. We're first-year MBBS students at MGMCRI. We'll be emceeing the entire session today. We're extremely honored and delighted to welcome you all to the Day 2 of Integrated International Conference held by the preclinical departments of Anatomy, Physiology, and Biochemistry of MGMCRI on the topic Exercise, Fitness to Therapy. Once again, we welcome everyone who's attending the conference online as well as offline before starting off with the scientific session for today.
We'd like to start off with our first session of the day by inviting our first speaker, Dr. Hariharan, Assistant Professor, Institute of Orthopedics and Traumatology, Coimbatore Medical College and Hospital, who has joined us online. We'd also like to invite the chairperson of the session, Professor Rajan, who is also online. Now, I request Professor Rajan, HOD Vice Principal, AVMC, to introduce our first speaker for the day.
Thank you, Doctor. Is it audible?
Yes, sir.
Okay. A pleasant morning to all. I thank the organizing team for giving me these opportunities, and I'll also congratulate them for this wonderful feast for all of us. And let me introduce the speaker today, Dr. D.R. Hariharan, Assistant Professor, Institute of Orthopedics Traumatology, Coimbatore Medical College and Hospital, has completed MBBS in Stanley Medical College, Chennai, MD Anatomy in Jipmar, Puducherry. He also completed DNP Orthopedics in Sundaram Medical Foundation, Chennai. He has 1 year teaching experience in anatomy and 8 years of clinical experience in orthopedics. He has been awarded Dr. J. Jayavelu Memorial Award for postgraduate at the 34th Annual Conference Association of Anatomists. His presentations has been selected twice for the Best Paper Presentation Madras Orthopedic Society. He also successfully completed Advanced Trauma Life Support course established by the ACS Committee on Trauma and AO Trauma course, Basic, Advanced and Master courses. He has been given a session on orthopedics in various NEET PG coaching centers. I welcome you, sir.
Thank you, sir. Thanks a lot for the introduction, sir.
Thank you, sir. I request all the participants to kindly maintain this online as well as offline etiquette for this session to have a proper learning. Thank you all. Sir, you can start your session, sir.
So I'll share my screen, sir.
Yeah, please, sir.
Sir, the host has disabled the participant screen sharing, it seems.
1 second, sir. The organizing team, can you please make sir to become host?
Dr. Hari, you can share your screens now.
Okay, sir. Sir, is my screen visible?
Yeah, we are able to see your screen, sir.
Fine.
Yes, sir.
Thank you.
Good.
So, good morning, one and all. I thank the Managing Director of Mahatma Gandhi Medical College, professors of and head of the Department of Anatomy, Physiology and Biochemistry for giving me this golden opportunity to speak in front of you. So, my topic is on functional anatomy of musculoskeletal system during exercise. So we'll go into the topic. See, as we all know,
Sir, Hariharan sir, you are muted.
Hari?
Yes.
Your video is also off. So can you switch on the video and also the audio?
Okay.
It's okay, sir.
Can you able to hear me now?
Yeah, yes, sir. Yes, sir.
Me and also we can able to see you.
Yeah, fine. Okay. So good morning to one and all. I thank the Managing Director of Mahatma Gandhi Medical College, and I thank the head of the departments of Anatomy, Physiology and Biochemistry for giving me an opportunity to speak in front of you all. And I also thank Dr. Nancy, who is one of my best friend who helped in integrating this session. So we'll go to the topic, and my topic in this morning is functional anatomy of musculoskeletal system during exercise. So we all know that there are 3 types of muscles in the body. One is the skeletal muscle, another one is the cardiac muscle, and another is the smooth muscle. And the skeletal muscle, it functions by moving the body. It helps primarily in the movement. Cardiac muscle, as we all know, it helps in the function of the heart, and smooth muscle, it helps in the function of our gastrointestinal system and the urogenital system mainly. So if you see the basic difference between these muscles, the cardiac muscle and the skeletal muscles, when you look into the histology, they give a striated appearance. So they are called a striated muscle. And the smooth muscle gives an unstriated appearance. And when you look closely into the histology of these muscles, the skeletal muscles, the fibers are longitudinally arranged. They have got striations in them, and they've got multiple nuclei which are placed peripherally. In contrast to that, the cardiac muscles are again longitudinally arranged, but they are branched, and at the branching points, you can see certain discs called as intercalated discs. And when you look into the smooth muscles are spindle-shaped muscles. They've got a single nucleus in the center of it, and they are unstriated muscles. So since our topic is more on the musculoskeletal system, I'll confine myself to the changes and the things that happens in the skeletal muscles, basically. So when you go into the structure of the skeletal muscle, there is always a confusion between what is a muscle fiber and what is a muscle cell. Both are the same. Okay, the skeletal muscle cell means it is muscle fiber. And when you take the muscle fiber, the muscle fibers are made up of myofibrils. Okay, and these myofibrils are made up of myofilaments, and the myofilaments are two in nature. One is the actin and another one is the myosin. These muscle fibers, so if you take these muscle fibers are surrounded by and connective tissue called as endomysium. Group of muscle fibers joins to form a muscle fascicle, and these muscle fascicles are surrounded by a connective tissue called as perimysium, and running within the perimysium are the blood vessels and the nerves, and the entire muscle fascicles are surrounded by the epimysium, which finally forms the muscle. Okay, so this is a basic architecture of a skeletal muscle. And when you look into the microscopic anatomy of the skeletal muscle, each myofibril has got a functional unit called a sarcomere, and sarcomere is the part which extends between the two Z discs. I will tell you what is mean by an Z disc in another slide. So when you look into the sarcomere is made up of two filaments. One is a thin filament and another is a thick filament. The thin filament is called as an actin. If you look into the actin arises in the form of an monomer called as G-actin. Each of this G-actin has got a myosin binding site. Okay, each of this G-actin has got a myosin binding site, and these monomers joins to form a longitudinal strand called as F-actin. So F-actin is a polymer, and this is the final actin, and this arises from the G-actin monomer. And the other filament which is seen in the sarcomere is the thick filament, and that is the myosin filament. And this myosin filament is seen in the form of a long chain, where you've got two kinds of filaments in it. One is the heavy chains, and another one is the light chains. So there are two types of chains in it. One is an heavy chain, another is a light chain. So this is the heavy chain, and you can see the light chains here. Okay, so there are totally 4 light chains in the myosin and 2 heavy chains in the myosin. Okay, so these myosins have got a head where you got 2 important sites. One is a site for the actin binding, and another one is a site for where the myosin ATPase binds. Okay, it's an enzyme where the ATPase binds. Okay, so when you look into these muscles, sarcomere further, so there are certain other proteins which are very important in the function of the skeletal muscle, and one is the tropomyosin, another one is the troponin. Tropomyosin is the one which lodges, or it lodges in the groove of the actin, and it closes the actin myosin binding site. And when you look into this tropomyosin is attached to an important another protein complex called as troponin. So troponin, if you see, there are 3 complexes in it. The troponin T is the one where the troponin binds to tropomyosin, and troponin C is the site where calcium binds, and troponin I is the site where the actin myosin interact. So these 2 are important proteins again in the skeletal muscle. Apart from these proteins, there are several other proteins that maintains a cytoskeletal network of the skeletal muscle. And to name few, they are the intracellular proteins, namely the titin and the dystrophin, the transitional complex, and the extracellular protein where you get the collagen. So these proteins mainly form the cytoskeletal network of the entire skeletal muscles. So a study by Ramaswamy et al. And Hughes et al., they showed that dystrophin is one which is mainly essential for lateral force transmission, and whereas titin and nebulin, which are one another proteins in the skeletal muscles, are important in transmitting the force longitudinally, and they are also responsible for the stiffness of the sarcomere. So when you look into the sarcomere per se, so this is how a sarcomere look into, and an electron microscopy picture of an sarcomere will reveal two kinds of bands in it. As we all know, these are all very basics. So this band is a light band, or also called as an I band, or also called as an isotrophic band, and this is the dark band where it is called as an anisotrophic band or A band. In the anisotrophic band, in the middle, if you see, there is a dense line called as M line, which bisects a lighter zone in the A band called as an H zone. Okay, so what is this basically? So if you go back to this slide, so you can see the actin and myosin overlap with one another. And the point where they overlap becomes the A band, and the actin where it is not overlapped by myosin forms the I band. So the area where only actin filaments are seen, we call it as an I band. So in this, the actin are attached to one another at a region called as Z disc. So the space between two Z discs, or the length of the muscle fiber between the two Z discs, is called as a sarcomere. So when it comes to the muscle, as we already discussed, the main function of the skeletal muscle is to move the body. Okay, so for the movement, it needs to contract. So how it contracts? It contracts in 5 stages. So in the stage 1, the myosin is attached to actin. Next, it gets attached to an ATP, where an ATPase work on it. It releases energy, and by the release of energy, a power stroke occurs, and the myosin moves over the actin. And after the movement, again, the myosin, it gets reattached to the actin. So this is how a muscle contracts, and this theory is called as a sliding filament theory. To facilitate the sliding filament theory and to understand the sliding filament theory, we can go through this short video where we can see the sliding filament theory being explained clearly.
Contract at a cellular level. An understanding of the structure of skeletal muscle is useful when learning how sliding filament theory works. Each muscle is made up of a number of bundles of muscle fibers. Each bundle of muscle fibers contains anywhere from 10 and 100 individual fibers. Each muscle fiber itself contains cylindrical organelles known as myofibrils, which themselves are bundles of proteins called actin and myosin. Surrounding the myofibril, there is a network of tubules and channels called the sarcoplasmic reticulum, where calcium is stored. Each myofibril can be broken down into functional repeating segments called sarcomeres. If we look at a two-dimensional model of a sarcomere, it consists of actin and myosin. When a nerve impulse arrives at the muscle, it causes a release of a chemical called acetylcholine. The presence of acetylcholine causes depolarization, enabling calcium to be released from the sarcoplasmic reticulum. The calcium binds to troponin, changing its shape, and so moving tropomyosin from the active site of the actin. The myosin filaments can now attach to the actin, forming a cross bridge. The breakdown of ATP releases energy, which enables the myosin to pull the actin filaments inwards, contracting the muscle. This occurs along the entire length of every myofibril in the muscle cell. When an ATP molecule binds to the myosin head, the myosin detaches from the actin and the cross bridge is broken. When the ATP is then broken down, the myosin head can again attach to an actin binding site further along the actin filament and repeat the process. This repeated pulling of the actin over the myosin is often known as the Ratchet Mechanism. This process of muscular contraction can last for as long as there are adequate ATP and Ca+ stores. Once the nerve impulse stops, the Ca+ is pumped back to the sarcoplasmic reticulum, and the actin returns to its resting position, causing the muscle to lengthen and relax.
So the video which we saw explains us clearly how a sliding filament works. And as we all know, when we talk about the muscles, the muscle main function is to contract. So based on the contractility, okay, and based on the enzymes which act in the muscles, and based on the myosin isoforms, we classify the skeletal muscle into further subtypes. So one is called as an type 1 fibers, which is also called as an slow oxidative fibers. type 2A fibers, which is called as fast glycolytic oxidative fibers, type 2B fibers, and type 2X fibers. So these are the subtypes in the skeletal muscles. And what is their details? See, type 1 fibers are the muscles which are having low myosin ATPase activity, but their mitochondrial content is very high. Okay, they have got low glycolytic activity and they are very, very resistant to fatigue. And these muscles are seen in the postural groups where it is helpful to maintain your posture for a longer time. So the next type of fibers which you commonly encounter in the muscle is type 2A fibers. And these type 2 fibers are also called as fast twitch oxidative fibers. These fast twitch oxidative fibers are rich in myosin ATPase content. They also have an high oxidative capacity, which means their mitochondrial content is also good. They have got a high glycolytic capacity, and these are relatively resistant to fatigue. And these can you able to hear me? I think.
Yes, sir. There was interruption. Now we are able to hear you, sir.
Yeah. So these are type 2A fibers. Type 2A fibers are the fast twitch oxidative fibers. And these fast twitch oxidative fibers, they have got high myosin ATPase content. Their oxidative capacity is high, and they still have got an high glycolytic capacity. And these are relatively resistant to fatigue. And these fibers are seen in the muscle groups which goes in for repetitive repetition of weight lifting. Okay, see, for example, biceps muscle, when the muscle load is given repeatedly, you can have an increase in type 2A fibers in them. And type 2B fibers have got high myosin ATPase activity. They've got less mitochondria in them. So oxidative phosphorylation is less in them. Instead, they've got an high glycolytic capacity. These muscles, they have a spurt of energy in them, but they are easily fatigue prone. So these muscles are usually seen in the persons who sprint for a shorter distance, maybe an 100 meters running. The persons who are involved in like Usain Bolt, the more type of fibers are the type 2B fibers. So what determines the type of fibers? See, normally when you see a muscle might contain more than one type of fibers, but the percentage of the fibers determined by its function and its fatigability. So why do we need a skeletal muscle? Do we need a skeletal muscle? Yes, we need skeletal muscle for a lot of things, for moving our joints. It acts as a shock absorber around the joints. It protects the joints, and it is also acts as a storehouse of glycogen. But apart from all this, the main function of the skeletal muscle is it acts as a pushing and pulling machine for us. So it is basically a machine which tries to push or pull. So when you see the muscle functioning in the pushing or a pulling pattern, and how does it function? Where does it function? To understand that, we need to understand the attachment of a skeletal muscle. So the skeletal muscle is attached usually to a bone by means of a card-like structure called as tendon, or a flat sheet-like structure called as an aponeurosis. And these tendons or aponeurosis are formed by the aggregation of the connective tissue around the skeletal muscles. So whenever you see a muscle usually has got two attachments, a proximal attachment and a distal attachment. And we normally call the proximal attachment as the origin and the distal attachment as the insertion. And it is also being said that insertion is the point where the movement occurs more. But this is always a myth, because there is more possibility for the muscles to move at both the insertion site and at the origin site, depending upon which end is fixed. See, for example, if you take this action here, one person is doing biceps curls where he is lifting a weight in his arm, and in the other side, he is pulling his entire body up. In both these actions, the muscle which mainly works are the biceps. Okay, so when you see on the other hand, here, the arm is relatively fixed, the forearm is free, and the forearm moves towards the arm. So this is a primary action of the biceps, and we call this as a standard mover action. On the contrary, if you see in this picture, okay, so where in a person who is doing pull-ups, the hand and the forearm are fixed to a point, and he tries to lift his body up. So the arm moves towards the forearm. In other words, the origin of the biceps moves towards the insertion, or the origin of the brachialis moves towards the insertion, which we call it as a reverse mover action. So most of the muscles will have a standard mover action and a reverse mover action. And when a muscle acts, it tries to contract, and there are two types of contractions basically. One is called as an isometric contraction, and another one is called as an isotonic contraction. What is called as an isometric contraction? In this isometric contraction, the muscle length remains the same, but the tone changes. See, for example, when you do a plank exercise like this. So when you do a plank exercise, or when you, for example, a day-to-day activity, when you lift a grocery bag in a mid-arm position, so the muscle length remains the same, but the tone changes. So this kind of contraction that happens in the muscle is called as an isometric contraction. And on the contrary, if the muscle tone remains the same and if the length of the muscle varies, we call it as an isotonic contraction. And there are two types basically. One is called as a concentric contraction, where the muscle shortens to lift a weight, for example. So that is, these concentric contractions are mostly used in strength training or power lifting. See, whenever you lift a weight, okay, so the muscle contracts to lift the weight, and whenever you're going to drop the weight, you're not going to drop it just like that. You're going to drop it very slowly. So the opposite happens in the muscle. The muscle tries to lengthen. So the lengthening of the muscle is called as an eccentric contraction. See, in this picture, if you see on the one side, the person is contracting the muscle, and the other side, the patient or the person is extending the elbow, where an eccentric contraction takes place. So contraction can happen both in a lengthening way and both in a shortening way. Accordingly, it is called as a concentric contraction and eccentric contraction. So after learning so much of the muscle function and how it works, see, we are going into a main topic called as an exercise. See, we all are confused with the terms called as in physical activity, exercise, and physical fitness. See, if you are an 90s kid, and if you ask your mother will tell always this thing: I am doing so much of household work, that is more than enough for me. They won't do any kind of exercises. They not even will go for an walking. But there are a lot of difference between a physical activity and physical exercise, or an exercise basically. See, physical activity, any movement that happens in the body that causes energy expenditure is called as a physical activity. But exercise is not like that. Exercise is a kind of physical activity where it is planned, structured, and you have an aim to improve your physical fitness by that. Okay, so don't confuse physical activity and the exercise with one another. This definition was given by Carl J. Kasperson in a literature. So when you take exercises are broadly classified into two types. One is called as an aerobic exercise, another one is called as an anaerobic exercises. Aerobic exercises are also called as an cardio exercises, which are all endurance exercises, which increases your cardiorespiratory effort. Okay, and on the other side, these are the resistance exercises where you use your strength to lift the weights and thereby building up your muscles. So there are basically two kinds of exercises in this. A classical example for this is, one side you can see in the picture a marathon runner. So usually the marathon runners, they run for a longer distance. Okay, so those kind of exercises where you run slowly and you run for a longer distance are a classical example for endurance exercises, and you lift weight for a shorter interval of time, and those exercises are called as resistance exercises. And there are a lot of things which happens in the muscle functionally when these kind of exercises are being done. So when you train a muscle, the muscle responds to in various ways, like the mitochondrial biogenesis happens in a muscle, angiogenesis happens in a muscle, fiber type transformation happens in a muscle, hypertrophy and hyperplasia happens, and there is an increase in contractile proteins, and there is also an increase in GLUT4 expression happens. There are a lot of other things. I have highlighted the important things which happens in a muscle during training. So this is a literature called an adaptation to endurance and strengthening by David C. Hughes. So he classified the endurance exercises and resistance exercises, and he saw what is happening in each of them. In endurance exercises, there is an enhanced cardiac output, there is a maximal oxygen consumption, and there is a mitochondrial biogenesis, and there is an increased capillary density. Whereas in resistance exercises, there is an increased cross-sectional area of the muscle. In resistance exercise, the neural adaptations plays an important and major role, and there is also an improved strength of the muscle. See, the important changes which happens in the skeletal muscle involves the mitochondria per se. See, when you see the exercise, we studied the exercise pattern in three ways. One is a short interval training, another one is a high intensity interval training, and another one is an long, slow distance training. So they took three groups of people. They put them into these kind of exercise regimen, where a group of people did a short intensity training. And when we studied the skeletal muscle changes, it was found that the mitochondrial numbers didn't increase, but the mitochondrial intensity increases. The activity of the enzymes in the mitochondria increases. Whereas on the contrary, if you do an exercise, which is kind of an endurance exercise, which is a long, slow distance exercises, we can see there is an increase in the mitochondrial content, and also there is an increase in the mitochondrial numbers. That is what we are saying. In endurance exercises, mitochondrial biogenesis is very, very important. So a brief review given by John O on adaptation of the skeletal muscles to endurance exercises and their metabolic consequences says that endurance exercises increases both mitochondria and its content. This is an important functional change which happens in the skeletal muscle following an exercise. See, apart from the mitochondrial changes, a lot of neuromuscular adaptation occurs during exercises. See, these neural adaptations again varies from resistance training or an anaerobic exercises to an endurance training or an aerobic exercises. In resistance training, mainly the neuromuscular adaptations plays a bigger role, where the supraspinal adaptations causes recruitment of more motor units, which causes an increased muscle activation, thereby increasing the force of the muscle. And it also helps in co-activation of the antagonist muscle. On the contrary to this, in endurance training, there is a decrease in number of motor units. There is an additional activation of synergistic muscle. The capillary density of the muscle increases, and there is a decreased muscle cross-section. That is why if you see a person who are doing endurance exercises or a marathon runner, they'll be very thin because their muscle cross-section decreases. That is why they become thinner and thinner. On the contrary, on the resistance exercise, the muscle cross-section area increases, so they become bulkier. So there is an interesting phenomena which happens in neuromuscular adaptation called as a spillover phenomena. Consider this model where one side, the patient has got an injury and the limb has been immobilized. On the other hand, the patient started doing the exercises. So the exercises which was done on the other side got reflected on to the immobilized side. So the patient had an increased, or the muscle cross-section improved on the other side also. This effect is called as a contralateral strength training effect. And this is mainly because of the neural adaptations. And this neural adaptations causes a spillover in the cortex, where a cross-limb cortical interaction happens and the spinal cord excitability happens following that, resulting in an activation of the muscle, which was not in use also. And this is better appreciated in an eccentric group of muscles rather than in the concentric group of muscles. So further transformations are seen in the fiber types also. So as we have seen, there are several fiber types in the muscle, type 1 and type 2 fibers. So whenever you do an heavy resistance training, there is an obvious increase in type 2A fibers, and there is a decrease in type 2B fibers, and there was no changes noted in the type 1 fibers. See, these skeletal muscle, though they contain several type of fibers, the area occupied by them depends upon the activity which is put on them. Okay, so skeletal muscle, when you see the muscle, they contain mixture of fibers, but when you put a muscle into frequent resistance exercises, you note that there is an increase in type 2A fibers in them. So obviously exercises have a change in fiber type. So this is an interesting article where they looked into the hypertrophic effect of a concentric versus eccentric muscles. See, when it was initially studied, they thought that concentric muscles are the muscles which are prone to more amount of resistance exercises, hypertrophies more. But actually things lot changed. Okay, so they did several investigations or several studies in that, and they noted that whenever there is a low load blood flow resistance training has been given, it gives an equal response to like that of an heavy load resistance training, because in load blood flow, so the hypoxia plays an important role, and that activates the muscle growth factors, which increases the muscle girth or the muscle hypertrophies. So does resistance training alone can build muscle mass? Is that phenomena correct? No, it is not that. So when you look into the effect of eccentric contractions, it was noted that whenever you do an eccentric contractions, the muscle also hypertrophies well, because of there is a greater disruption of the contractile and supportive elements. There was an anabolic response which is induced, which gathered more growth factors. So release of myokines and satellite cell activation happens, and following which muscle hypertrophies. And these muscle hypertrophies, especially to prevent future injuries. And as we have already seen, the type of fibers which hypertrophies in eccentric contraction is more often type 2 fibers. And this is to be noted in endurance exercise, as the hypertrophy occurs due to two main things. One is due to muscle protein synthesis, and another one is due to activation of mTORC protein. It is also due to an activation of mTORC protein. Okay, so the next important change that happens in the skeletal muscle is the expression of the GLUT4. Okay, so we all know in the skeletal muscle, the primary source of energy is glucose. So for the glucose to enter into the cell, it requires two things. One, it requires insulin for transportation of the GLUT4 to the surface of the cell membrane, or it requires exercise to do that. Okay, so GLUT4 protein can be translocated to the plasma membrane from the inner aspect of the cell, either by insulin or by doing an exercise. Suppose if a patient is diabetic where the insulin level is low, so how to translocate this GLUT4? That is where exercise plays an important role. And there is an interesting article given by Witzkak where the signaling mechanism in skeletal muscle was studied in two responses, one by acute exercises, another by chronic exercises. And what they observed is, when you do an acute exercises, there is a translocation of GLUT4 from an intracellular location to the plasma membrane. Chronic exercise, on the contrary, it improved the mitochondrial biogenesis, it changed the fiber type, it increased the GLUT4 protein expression, thereby it increased the expression of GLUT4. So the GLUT4 number increased automatically when you do chronic exercises. So the take-home message is very simple. Okay, if you are a diabetic patient, it is always better to do exercise, whether it is an acute exercise or a chronic exercise. The GLUT4 expression and the GLUT4 translocation to the membrane is increased, thereby the need for insulin decreases in a patient who has gotten diabetic. So this is an important biomechanical thing which happens in the cells following an exercise. So is there any other factor which enhances your training or enhances your endurance? Yes, there is another important component called as a muscle extracellular matrix tendon unit stiffness, where these adaptations enables the body to store and use the elastic energy more efficiently. These stiffness or this unit prevents the injury to our muscles. That's very, very important in an exercise training. So since we have seen about the different aspects of changes in the muscles following the exercise, there are several myths in young athletes. So usually when you ask a young patient to go to a gym, they will tell that it will cause more injury, my flexibility will go off, and my muscle mass cannot increase. But all these are myths. Okay, so whenever there is an young athlete, if he is put into lighter weights and if the number of repetitions is more, the muscle hypertrophies well. And these hypertrophies not only is influenced by the weight they took, but also by the neural adaptations which undergo in them. So in an young athlete, strength training is important and it can be done. And on the contrary to the other side, see, in the skeletal muscle, when it ages, there are a lot of changes again happens, where there is a decrease in the skeletal muscle fiber, which we call as sarcopenia. The muscle firing of motor neuron decreases, the tension in the muscle decreases. Because of this, the patient have a frequent fall, which can result in several kind of fractures in them. So osteoporotic fractures are very, very common following a fall in the elderly people. So in order to avoid that, even elderly people can do exercises, can do strength training, which regains their power, and it also reverses some amount of the muscle decrement which happened in them. So there is a real changing trend where it was initially thought that exercising for a longer time will increase your oxygen consumption, will increase your endurance capacity. And whenever you work against an heavy load, your muscles will become bigger and stronger. But literature is changing, the evidence is changing, where an high intensity short duration interval training will increase your endurance level, will cause hypertrophy of your muscle, and also the load resistant training will increase your muscle size. Okay, I hope I conveyed the important aspects of different kinds of training and their impact on the muscle anatomy and muscle histology. Okay, thank you for your patient listening. Thanks a lot.
Thank you, sir. It was a wonderful session, and we are very excited with all this video, which clearly spent what we should understand, which cannot be explained by the word. I think the session is open for all of you to clear your doubt. Sir is always here. Organizing team, please give the mic to the delegates.
Good morning, sir.
Good morning.
So myself, Nirmal, your student. I think you can remember me.
Yeah, Nirmal, yeah.
How are you,
How
sir?
are you?
Fine, sir.
Yeah, tell me.
Sir, I have a doubt, sir.
Yes.
Could you clarify the words like muscle relaxation, eccentric contraction, and muscle stretching? The difference between these three terminologies.
Okay. See, contraction happens in two ways, Nirmal. One, it can shorten the contraction can cause shortening of the muscle. At the same time, contraction can cause relaxation of the muscle. That is what I told you. When you lift a dumbbell, okay, you contract the muscle where the muscle shortens. And when you slowly drop the dumbbell, again your muscle contracts, but still the muscle is lengthening. So in both this, muscle contraction happens. But when you sit idle without lifting any weights, your muscle is in a relaxed state. So that is what we call this in relaxation. So in both this contractions, okay, both in lifting of weight or dropping the weights, the muscle contracts. But in one, it shortens, and in the other, it lengthens.
Okay, sir. Thank you.
Any other?
Can I ask a question?
Yes, sir. Yes.
Thank you. Very good talk on basic anatomy. Type 2A, type 2B, and type 2X. You didn't tell us much about the 2X, so that's one question. And we know very well from clinical medicine that whenever we are not using a muscle within a few days and weeks, type 2B atrophy occurs very quickly. And steroids often cause type 2B atrophy. Can you please tell us a bit more about the 2X and the genesis of it? And then type 2A and 2B, what are the controllers, or either by exercise or by genetic, and the effects of therapy? Just a type 2 fiber for the sub-analysis to understand what is good for us.
Yes, sir. Yes, sir. Type 2 fibers, we classify them into type 2A, 2B, and 2X fibers. 2A fibers are where you have got more amount of the mitochondrial activity and more amount of glycolytic pathway which acts. So type 2A fibers are mainly used for doing resistant exercises which involves lifting of weights frequently. On the contrary, type 2B fibers and the 2X fibers are the fibers which have got more amount of glycolytic pathway. Their activity are more fatigue prone, and they are morely seen in the extraocular muscles. Example is an extraocular muscle where the movement is very fast, but they are more fatigue prone. And thus, steroid plays a role in muscle building. Yes, steroid plays a role in muscle building, but there are also detrimental effect of steroids when we use it for muscle building, and it should be used in a guided manner. And when you say disuse, when you don't use a muscle, when you keep the muscle idle, yes, obviously the muscle atrophies, and type 2B fibers atrophies more when compared to the other fibers.
The reason I ask about this is because in muscle dystrophies and genetic muscle disorders, we recommend physiotherapy, which is basically exercise and different types of strength and endurance trainings that the patients go through. Which type of fibers are we specifically targeting? Type 1 or the subset of 2 fibers? We don't recommend that specifically, but what actually happens? Duchenne muscular dystrophy, getting exercise, which muscles are we trying to promote?
We try to promote mainly the type 2 fibers, sir. Type 2 fibers.
A, B, or X?
A fibers.
Thank you.
Any other questions from participant, online or offline? Organizing teams, anybody is there offline?
No, sir, no more questions.
So shall we end the session?
Thank you, sir, for this very informative session. We also thank Professor Rajan for chairing this session. The memento and e-certificate will be sent to you. We also thank the online and offline participants for asking questions and making this discussion very dynamic. Thank you.
Thank you.
Thank you, ma'am.
Moving on to our next session, we'd like to call on stage our second speaker, Dr. John Frederick, Associate Professor, AIMS Kalyani, West Bengal, and the chairperson of the session, Professor Jayalakshmi, Professor and Head of Department Physiology, SSSMCR, who will be joining us online.
Jayalakshmi, madam, you have been asked to.
Yes.
Yes. Yes, you are audible. Please, madam.
Thank you, sir. So thank you for the opportunity given to me. A very good morning to one and all. Today, I think, is the International Day for Older Persons. October 1st is the International Day for the Elderly. And the theme is Resilience of Older Persons in a Changing World. So I think this topic is very apt for this day. And it's my pleasure to introduce the speaker of the day of this topic, Dr. Jean Frederick. The topic is exercise and geriatric health. Dr. Jean Patrick Frederick, his academic career, if you say, has been associated with Pondicherry. He has done his MBBS from Pondicherry Institute of Medical Sciences. His post-graduation is from St. John's Medical College, Bangalore, senior residency from JIPMER, and he was an assistant professor in the same NGMCRI. And at present, he's working as an associate in AIMS Kalyani. His research interest is on cardiovascular physiology, exercise physiology, body composition, and also research ethics. And he's got 11 publications to his credit and 8 book chapters. He has received Best Research Work Award in Cardiovascular Physiology in 2021 ASOPICON. He also has 2 extramural grants. So, sir, a warm welcome to you. And I think we will definitely be taking home a good message. Welcome, sir.
Thank you, ma'am, for your warm introduction. Good morning, everyone. Okay, good morning. Before starting my session, I would like to thank the organizing team for giving me the opportunity to give a talk in this conference, especially Professor Janet Berlin Raj. And I feel very happy to come back here and share some of my works in this field, which I have done here also when I was working here. Okay, so as ma'am said, today is considered as International Older Adults Day. So I think I was about to say that this would be an apt topic to speak today. Fine. Now, what is aging? Why do we need to think about aging? What do we need to study among these older adults? One is during aging, there is progressive loss of physical, mental, and cognitive integrity, leading to impaired functions, and increased vulnerability to morbidity and mortality. These are several definitions given by several papers and several authors. There is progressive degeneration of these tissues that have a negative impact on the structure and function of the vital organs. So in research, we do assess all these functions. For example, we check for the loss of physical functions, mental health, and cognitive functions by several questionnaires and several assessment methods. So we will deal with what are these assessment methods in our forthcoming slides. Generally, older adults are considered to be people who are above 60 years of age. What happened during this older age? There are several chronic issues which needs to be treated, and then they need long-term treatment during this period. The most common one is arthritis. People get arthritis, that is 29.3% of the population. This was done in a census in 2011 actually. It is projected that all these chronic diseases could increase as the years increases. So as the arthritis, mostly they get arthritis, then hypertension, diabetes, asthma, heart disease, and many other diseases. Are these diseases preventable? What are the causes for this disease? Most of these diseases are due to lack of physical activity, sedentary lifestyle during their younger age. Can this be prevented? Yes, they can be prevented, or they can be delayed by several ways. Now we see that there is increasing trend of older adults all over the world, especially in India also. We see that there is increasing trend of older adults because of higher healthcare facility which is available in our country, like which is seen in Western countries. So when this increase in incidence of or increase in population of older adults is there, we can also see that the problems among them will increase. How will we address these? More than urban population, there is also increase in incidence of or increase in population of older adults in rural India. Are they having proper healthcare facilities among for these older adults? We see that the dependency ratio for these older adults is higher, particularly in rural India. The quality of life among the older adults has been studied in many studies. What is quality of life? You check the social life, environmental life, psychological and physical health of these older adults. Most of the studies have said that the quality of life among the older adults has decreased due to many factors. During aging, there is loss of muscle strength, there is reduced flexibility of the muscles, there is limited exercise capacity. This leads to loss of physical function and disability. This is a part of the physical health of the older adults. Why all these things happen? All these things takes towards sedentary lifestyles of our people. So the poor functional ability and increasing dependence of the population and requirement of hospital services, all these affect their quality of life. As I told you already, this increasing dependence among the older adults affect their quality of life lots. If we see in the recent times, particularly during the pandemic, when we were under quarantine, older adults were affected most. That too, people who are living alone, because they had less care during this time, and then there are no people to help them for moving around or to buy medicines or to buy food. All these things were seen. So as I told you already, quality of life has 4 components. One is physical health, social relationship, environment, and psychological health. Most of the studies says that physical health and psychological health has been affected more among this geriatric population. This reduction in quality of life results from social isolation, depression, fear, and financial crisis. Most of this can be addressed by proper healthcare, proper counseling to the family members. Generally, older adults or geriatric people, they don't discuss their problems with their family members. These were also lots of surveys and psychological studies which were done among the older adults, which says that most of them were under depression, particularly people living in rural India. they felt that they were socially isolated, and then lots of them had depression. Maintaining functional ability and coping with functional limitations are the key healthcare challenges which we need to address among this population. Loneliness negatively impacts the physical and mental health of the older adults. This physical and mental health of the older adults, particularly when it was studied among the quarantine period, it was affected most. We conducted a study just before this quarantine period, or before this COVID pandemic. We found that physical and mental health status of these people, particularly if we see around our institution here, there is old age colony here. There are several areas where lots of older people are living. When we assess their quality of life, it was compromised. I can share you some of the data which we did here in MGMCRI. When we studied here, we found that around 18 to 20% of the population had poor quality of life. We also tried to find what affects their quality of life. Generally, their social and physical health were affected among them. Because of that, their quality of life were poor. And we didn't study among the institutionalized people, those people who are living in old age colony. We did the study among the people who are living with their families. Even with their families, with their family support, several older adults reported decreased quality of life. There was strong association between the physical activity and their quality of life. Most of them, we assessed their physical activity level using questionnaires like International Physical Activity Questionnaire. 66.3% of them reported that they were having sedentary lifestyle. Around 23 to around 40% of people reported that they're having moderate to heavy activity, which is quite less. How do we assess the quality of life? We assessed using some questionnaires. There are 4 components, as I said: physical domain, psychological, social, and environmental domain. People who are living, who are having moderate to heavy activity, we found that they were having better quality of life compared to people who are having sedentary lifestyle. We also assess their physical functions. Physical functions in the sense how their muscle function works, how they are able to move. All these things can be assessed by several methods. That is, one such method is short performance physical performance battery of test, which is being recognized by Fit India movement and also recognized by WHO. One such test is standing balance test, which we found that it was better among people who are active. Walking speed was better among active people. Grip strength were also better among the active people. So this says that we need to counsel the people to be physically active. Can it be only good for older people, or can also be detrimental for older people? The physical activity. There are both ends. Okay, what happens during aging? How do we address those things? During aging, there are several multiple processes happening. One is there is inflammation, there is muscle loss, increase in insulin resistance, there is dyslipidemia, hypertension, there is increase in oxidative stress. All this leads to several chronic diseases like cardiovascular disease, increase in fall among the older adults, sarcopenia, which means decrease in muscle quantity and quality of muscle, increase in incidence of osteoarthritis, increase in metabolic syndrome, dementia, type 2 diabetes mellitus. All these can be prevented by increase in physical activity, and also intervention of physical activity can also help them to improve their lifestyle. There are several diseases which happens during elderly population or older people. One such disease is cardiovascular disease. I will discuss 1 or 2 common diseases which we see. Cardiovascular diseases are the leading cause of mortality in elderly people worldwide. The level of total physical activity and exercise with appropriate intensity and volume lead to increased cardiac cell survival. There is something called as dose-response relationship. As we increase the intensity of exercise, you get a better lifestyle, better quality of muscle, better quality of life among these people, not only older people, it also applies to all age groups. It plays an effective role in prevention and control of cardiovascular diseases, including heart failure in the elderly people. How it does this? It reduces apoptotic and necrotic signaling pathways and improving their mitochondrial functions. Okay, I was telling that, is there only good effects of physical activity? Is there any harmful effects? Yes, there is. Suppose if a person is having a known case of coronary artery disease, can we advise him to walk as fast as he can? No. Sometimes if when their physical activity increases, they might get angina. So there is a need for proper study to tell them. Each patient should be studied at what level of physical activity a person should be doing. This is called as exercise prescription. When we are, for example, if a person is a known case of angina, we are doing treadmill testing to find whether the person is having treadmill positive or is there any underlying coronary artery disease for this patient. So when you are doing a treadmill testing, we need to know that at what heart rate, at what level of physical activity he might get angina. Based on this test, we can also prescribe exercise, that at what frequency, what intensity, what time, and what duration a person can perform exercise in his daily life. This will help them from detrimental effects of exercise. Sometimes the person may be having weak muscles. So if they go alone to the community to walk, they might fall at sometimes. So we need to counsel them that how far they can walk. Do they need a support when they go out for walking? According to JNC, more than 2/3 of the older adults over the age of 65 had high blood pressure. Several studies, this data which is shown here is a meta-analysis which is done recently, which shows that lots of studies have addressed this hypertension, and then they have said that people who are like that is a therapeutic intervention of physical activity decrease the systolic blood pressure and also diastolic blood pressure among hypertensive people. There was a drop in 6 to 8 millimeter mercury of systolic blood pressure in most of the studies. There were also reports of around 12 millimeter mercury, which is actually significant compared to sedentary people with sedentary lifestyle. How this is not considered as a main treatment. This is also an adjuvant treatment along with the antihypertensive which we are prescribing. Suppose if a person is pre-hypertensive, those pre-hypertensive people should be addressed with physical activity suggestions, that is exercise prescriptions, which might help them to decrease their blood pressure. There seems to be increased improvement of exercise-induced endothelial function, which releases vasodilators such as nitric oxide, which helps in decreasing the blood pressure. So we know that type 2 diabetes mellitus occurs because of increased body fat percentage in our body and because of increase in insulin resistance. Diabetes can be prevented among people with increase in physical activity levels. Among older age group, if they are having diabetes, we also have to prescribe proper exercise for them so that their sugar levels can be maintained at appropriate levels. Sarcopenia. Sarcopenia means decrease in muscle size and muscle strength, which plays an important role in development of disorders such as cachexia, osteoporosis, disability. It also causes mortality due to several reasons among the elderly people. How are they studied? Decrease in muscle size. We also had a discussion during our workshop how the sarcopenia is being diagnosed, how we can assess different body composition, parts of body composition in our body. So muscle size is assessed by many methods. One is by bioimpedance method, where we measure the body fat percentage and also the muscle mass. There are also ultrasound studies, CT scan studies, which has compared with the people who are sedentary lifestyle and physically active lifestyle. And then they found that people who are having increased muscle strength or muscle size were having better life or better, healthier life compared to sedentary people. Aerobic exercise, and sir was discussing in our previous session about different types of exercises. Aerobic exercise were found to prevent the incidence and development of sarcopenia by increasing the biogenesis and mitochondrial dynamics. Resistance exercises prevent a decrease in muscle mass and strength by stimulating the hypertrophy. So if a person is having sarcopenia, that is decrease in muscle strength and decrease in muscle size, resistance exercise is prescribed more. You may ask me, how do you advise a person who is around 70 years old to perform a resistance exercise? Are they supposed to do go to gym and lift heavy weights like 10 kg or 15 kg? No, it's not like that. They can be advised to do some simple aerobic and resistance exercises at their home. So this is recent concepts of counseling home-based exercises for older adults. For example, if you want to advise some resistance exercise for a 75-year-old person, you just take a 2-liter bottle or 1-liter bottle based on their capacity, fill water in that bottle and ask them to lift that bottle several times. So that's a kind of simple resistance exercises which can be done at home. Now, several diseases, for example, if you take the COVID-19 pandemic, we found that this geriatric population were found to succumb to this COVID-19 and die because of several reasons. Whoever had chronic diseases. The reason being attributed to one concept called as inflammaging, increased inflammation among aging population. Because of increasing inflammation, there seems to be increase in incidence of cardiovascular diseases, type 2 diabetes, CKD, cancer, depression, dementia, osteoporosis, sarcopenia, anemia, etc. So all this increase in inflammation leads to premature mortality among the population. So this inflammation was studied more during this COVID-19 pandemic. Why older adults were succumbing to the diseases? Not only COVID-19 pandemic, any other infectious diseases, they succumb easier compared to younger population. Why? In a normal person, if they are under increase in pro-inflammatory diet or junk foods or sedentary lifestyle, it leads to chronic systemic inflammation. So as they age, as they become older, this inflammation increases, which leads to elevation of cytokines in their circulation in general. So this process is called as inflammaging. Because of this inflammaging, this several infections like SARS-CoV-2 causes hyperinflammation among these, which can lead to increased risk of death among these older people. So lifestyle changes is a better thing, simpler thing, which can decrease the chronic inflammation and high cytokine levels among these peoples. So as I told you, this more of social isolation has been discussed more during this COVID-19 pandemic, during the quarantine. Before this also, this social isolation of the older adults has been studied. So they were found to have depression when they were socially isolated, and then they were sedentary. There was more of decrease in anti-inflammatory process, antioxidant defense, learning and memory were affected, neurotrophic factors were decreased, endorphin factors were decreased, immune system were decreased, neurogenesis were decreased. All these were counteracted by increasing the physical activity levels. There are several studies which gave therapeutic intervention of exercise around 6 to 12 weeks, which they found that there was significant difference or significant improvement in all these processes. So social isolation leads to inactivity among the older adults, which led to depression, which led to sarcopenia, which led to frailty. Frailty is also mostly commonly studied. I think here also one of our faculty from community medicine was studying on frailty among the older adults, where they found that there was increase in incidence of fall among the older adults because of increase in sarcopenia and then increase in weakness among them. So how do we address this? WHO has given a guidelines of physical activity behavior for all age groups. Particularly, they have given highlights for older people. So what are these guidelines? This has been also recommended by Fit India movement. Older adults should do at least 150 minutes to 300 minutes of moderate intensity aerobic physical activity. How do we classify this mild, moderate, and severe intensity? based on the metabolic equivalence. There are several compendium of physical activities which is available online. If you just say that, if you type as compendium of physical activity, it will say what are the mild activities, what are moderate activities, what are heavy activities. Mild, moderate, and severe can be classified based on the increase in heart rate when a person is performing, increase in oxygen consumption when a person is performing any activity. So there are several tables which are available. Even this activity need not be only gym-based activity or outdoor activities. It can be home-based activities. What we do in our daily life, household chores, washing dishes, cleaning the floor, washing clothes. All these are some of the activities which can be done at their home. So these activities can be recommended, which may improve their lifestyle. So they should do muscle strengthening exercises at moderate or greater intensity 2 or more days a week. A part of their weekly physical activity, older adults should do varied multi-component physical activity. Instead of doing only either aerobic activity or resistance exercise, a combination of activities can be advised to them, which may improve their lifestyle. I'm sorry. As I told you, Fit India has recommended all these guidelines in their protocols. Fit India came up with several fitness protocols and guidelines for older people, that too, particularly 65 plus 8 years. They have given guidelines for children. They have given guidelines for younger people between 18 and 65 years, more than 65 years. So I will just go through what are this physical fitness protocols and physical activity which are recommended for older people. They have recommended flexibility related activities, strength related activities, and balance related activities. So to increase the flexibility, they have recommended like just do simple exercises using a towel, shoulder upper arm stretch, lean on the wall, and then walk over the wall with the hands until they reach the top of the wall. Chest stretch exercises, calf stretch exercises, which increase their lower muscle strength. So these exercises are advised based on which improves their upper body and then the lower body as well. These are some of the few examples which is given. There are lots of other exercises also which are recommended. These are simple exercises which can be done at their home. Some exercises like child's pose, doorway stretch, cross arm stretch just by sitting on a chair, and then forward bend, knee to chest stretch. All these are some of the exercises which can be recommended among these people. To increase the strength, we can ask them to do push-ups on the wall by standing, sit-ups, and then straight leg raises to increase their lower body strength. So increase in upper body and lower body is important. Lower body strength increasing will make them walk better and then decrease in incidence of falling among the older people. Balance test can be done just by having a chair. They can hold a chair and then do calf rise to increase their balance activity. Single leg stance, leg swings test, leg swing exercises. These things can be done. Spot running, walking on toes, climbing the stairs, jumping jacks are some of the simple exercises which can be recommended among these people. As I told you already, there are several home-based exercises which can be suggested. Like just by sitting on the chair, we can ask them to do some simple stretch exercises which can improve their strength and agility. As a researcher, there are several ways of physical fitness assessment methods to assess the flexibility, lower body strength, agility and balance, body composition, and aerobic and cardiovascular fitness. Based on these parameters, we assess the physical function of these people and giving them intervention wherever they lack. That would be a better way of intervening and then improving their health. Now we are taking many, now we are in this local area, we see lots of H1N1 infection in which older adults are affected more. We are taking COVID-19 vaccine. Several studies have said that people who are having better activity will have better immune response to vaccine. Suppose if a person is having taking a vaccine, if he increases the activity level after taking the vaccine, the immune response were found to be more among these people. This study was done for H1N1 vaccine. COVID-19 vaccine, they have not come up with any such results, but it helps actually. So in general, I would like to suggest that people in this age group, they need better support to improve their quality of life, particularly their physical health. Physical increase in physical activity, particularly by exercise prescription, will increase their quality of life. Thank you.
Thank you, sir. It was an excellent insight into the quality of life of the elderly and also the role of exercise. Thank you very much. Sir, I have some basic questions. Can I ask?
Yes, ma'am, please.
One is whether meditation can be done before exercise or after exercise in the elderly, sir. Is there any differentiation?
Ma'am, I think it can be done at any time, but I'm not sure about the studies which has better improvement. I'm not sure about that, ma'am.
Thank you, sir. And the other one was exercise prescription you were talking about, sir.
Yes, ma'am.
Like, is there any general rule which we can tell the adults, the elders? Like, for example, you said when going out, always go with main company. So like that, is there any other general rule that they have to follow, or is it customized?
It is actually customized, ma'am, but ACSM gives some guidelines on exercise prescription. Basically, it's called as FIT principle. That is frequency, intensity, and duration. So how many times a person should do the exercise? For example, 3 times a day, and whether the person can do mild exercise or moderate exercise, how long, 20 minutes or 30 minutes in a single bout of exercise. There are several guidelines, like ACSM gives such guidelines how to prescribe exercise, ma'am.
Thank you, sir. Any other questions?
Dr. Jean, you were saying about, I have a question. Myself,
Yes,
I'm Dr. Janeth. I have a question for you. People are saying that vegetarian diets are better, non-vegetarian diets are not so good. In your research, did you find any difference in that?
Sir, I have not found any difference in that. I have to check with that,
Not
sir. I don't think.
Thank you. Thank you for bringing out the Fit India Movements guidelines.
Yes, sir.
We have one more question.
I can speak. No need. This is a question is not like the same related to Dr. Janeth. He told, but when you relate the diet and the exercise,
yes, sir,
which is more relevant?
Sir, actually both are relevant, sir. For example, diet means we prescribe or we suggest high protein diet if you want to increase their muscle mass. If you want to decrease their body fat percentage, if a person is obese, we also suggest that decrease their fat content. For example, we can.
Sir, I'm not going into the detail of the diet. This one, basically, yes, this or that, and how it is. So which one to adopt first? If I have a problem in physique and I weight and I'm over 65, weight is there, what should I adopt first? I have to reduce, regulate my diet, exercise, or go for exercise, which is earlier.
First, I would suggest first exercise and then diet, sir.
I don't know. It appears diet is very important.
Okay, sir.
I have a question.
Yes, sir.
Yeah, thank you, Professor Jean Frederick. Very good talk. I'm actually a neurologist. I have a question. In one of your initial slides, you showed us the changing demographics of elderly population over 65 in India. Now, in India, the frailty and aging seems to be much earlier by as much as 15 to 20 years compared to other countries that have been studied. Now, we know it's compared to the West, we are aging about 20 years earlier. The reason for that, if we know it, and secondly, what's the comparison figure to China or Southeast Asia, which are our more nearer genetic profiles? So 2 questions there. What is the reason for the earlier aging? And do we age as fast as the Southeast Asian population and the Chinese population? Or is it just a Caucasian versus Oriental genetic comparison?
Sir,
Any
if you are
studies
asking, sir,
Yes.
if you are asking that physiological aging among the individuals of same age groups, is that your question, sir?
And more of genetic profiling, because all the data that we have, that one that you showed, is that Indians are aging 15 years earlier compared to the Caucasian, Western American, European population. My question
sir.
is, what is the
Why?
comparative
What is that?
data?
What?
Comparative data to Southeast Asian and Chinese demographics in regards to aging? Are they also aging quicker, or they're aging in the 70s and 80s?
Sir, I'm not sure about the other countries, but several data suggest that Indians, this trend is seen because of their sedentary lifestyle and their lifestyle changes only, sir. But I'm not sure about the comparison with other countries.
So your hypothesis is that we Indians have behaviorally made ourselves worse rather than blaming it on the genes. And so it's a behavioral correction, because just now previous sir asked a question about exercise and diet. So is it because of lack of awareness? Because we have usually survived on plant food. Traditionally, Indians are vegetarians for centuries, and then this meat diet we had in minimum amount. But is that the increase that's contributing to oxidative stress?
True, sir. That too increase in the recent times, that too in the recent two decades.
So the younger children need. Okay. Second question I have, you raised the issue of frailty without clearly defining it. Frailty, and then you also had obesity and sarcopenia you talked about most. Elderly are having this new phenomena of sarcopenic obesity, where so can you touch upon frailty and the concept of sarcopenic obesity, and whether exercise or diet or anti-inflammatories will come in from a research perspective?
Okay, sir. Sarcopenic obesity is seen among the obese population who also have less physical function, less muscle size and muscle strength. So this is also a increase in incidence of this sarcopenic obesity is also seen in the recent times, and then more researches are done in the recent times only, sir. Regarding frailty, there is increase in fall among the people due to decrease in the muscle strength and muscle size. This is seen among the.
Is frailty equal to falls, or is it something different? Frailness.
Equal to what, sir?
Is frailty equal to falling tendency, or is frailty different?
Frailty, because of frailty, people fall, sir.
Okay. Thank you, sir. Thank you very much. Nice talk. Thank you, sir.
If there are no other questions, any other questions from the online participants, offline participants? If there are no other questions, we'll end this session. It has been a great honor to see Jean Frederick growing, because he has been associated with us. Then he left to Ames Kalyani. One thing I would say about Jean is like his consistency. He's so consistent in doing whatever he does. He never keeps himself idle. Thank you, Jean, for accepting to come to our conference and deliver the talk. As a moment of appreciation, we would like to honor you with a memento. Also like to give you an e-certificate, which will be reaching your mail. To the chairperson, Madam, thank you so much for joining us. We will also like to honor you with the e-certificate. This e-certificate will reach you through mail. Thank you, Madam.
Thank you very much, sir.
Thank you.
Thank you, sir. Now we request everyone who's here to gather us for a high tea. For everyone attending online, please zoom in exactly sharp at 11 a.m.
There is no sound. Please give some sound.
Dr. Senthil, am I audible?
Yes, sir.
Yeah,
Audible.
can I have your video on?
Yes, sir. Done.
Yes. Yeah, we can see you. Thank you. Just a moment.
Welcome back, everyone. Hope you enjoyed the high tea. And now we'd like to move on to the next scientific session of the day. For that, we'd like to invite our next speaker, Dr. Senthil Kumar, Associate Professor, AIIMS Mangalagiri, Andhra Pradesh, who has joined us online. I also welcome the chairperson of the session, Professor Paramita Bhattacharya, Professor, Department of Physiology, TIMS. Now we'd like to request our chairperson, Professor Paramita ma'am, to introduce the speaker for the session, Dr. Senthil Kumar.
Good morning, one and all present here. Good morning, Senthil.
Good morning, madam. Good morning.
How are you?
I am very fine, madam. Happy to meet you.
Happy to meet you after 4 years.
Yes.
Okay, so it's very much pleasure and privilege for me to introduce today's speaker, Dr. Senthil Kumar Subramaniam, who is currently working as an Associate Professor of Physiology in AIIMS Mangalagiri. He is 14 years teaching and research experience. Can I have his CV slide, please? He started his career in the JIPMER after post-graduation. Then he worked in several other institutions before he joined AIIMS Mangalagiri in 2018 as Assistant Professor of Physiology. He, along with MD and DNB Physiology, he has also additional degree like MSc Yoga Therapy, Medical Exercise Specialist, Isaac Level 2 Kinanthropometrist, Diploma in Health, Fitness and Lifestyle. His research interest is yoga therapy and exercise physiology, and he has got 37 publications so far in national and international journal with 598 citations. He has also been awarded several awards I would like to mention, like International Young Scientist Award in the Second International Young Scientist Congress, which was held in 2015-16. In addition to that, he also received Best Oral Presentation Award in APTCON 2011 and Basic Medical Science E-Conference 2021, which was held during the COVID era. So that is about his professional Dr. Senthil. So it will be incomplete if I don't say a few words about Senthil as a person, because I have worked with him for almost 3 years when he was with us in Pondicherry Institute of Medical Science. He is a very wonderful colleague. Wherever we used to get stuck, let it be in computer application or statistics or physiology subject itself, he was always there to help us, guide us and support us. Those 3 years will be always memorable. We won't forget that. So today he is going to give a talk on corrective exercise physiology, mobility and stability. So without wasting my time, I request Senthil, can you please start your presentation for your topic? And it's a request, and please keep your time limit within 45 minutes so that we can interact with you.
Thank you, madam. Thank you very much for this kind introduction. I will start immediately, madam. Is it visible, organizers? Am I visible and audible?
Yes, you are visible as well as your slides also audible.
Okay, madam. Okay, thank you very much. First of all, I want to thank the organizers for giving me this opportunity to share my experience on this topic. This is a very, very interesting topic, the physiology of stability and mobility training. As madam has told, for time constraint, I will be going directly into the discussion. First, let me start with the clinical scenario. Mr. Kumar has come with the pain in the lateral epicondylitis, which we commonly known as tennis syndrome, okay, tennis elbow. Okay, he consulted a medical exercise physiologist, so who examined him and gave him treatment for the same. Rest and stop doing the triggering activity for some time, cold compress for inflammation and give a list of exercises. And he also advised him to meet a corrective exercise physiologist. Mr. Kumar did all this treatments. He felt relieved. So he didn't feel the necessity to meet a corrective exercise physiologist. But the problem is, when he was playing again, the pain recurred. It was coming again and again. So finally, he decided that he will meet a corrective exercise physiologist. The corrective exercise physiologist asked him a question: what is your occupation and what you are doing for the life? Then Mr. Kumar told that it is a desk job and I have to spend most of the time in sitting posture only. Then the corrective exercise physiologist asked how he's going to sit and examined him, and they gave him stretch for chest muscles and strengthening of the back muscles. Mr. Kumar was confused. I have come with a pain in the elbow, and why he's trying to correct my shoulders and all. But he did the exercises. But still then, he was not convinced, and his posture was not corrected even after 2 weeks of doing it. So let us go through this discussion and have how we can help Mr. Kumar more and what better can be done for him to treat him better. So that will be the basis for my talk today. Okay. Today, I believe that there are many concepts in research, but it has not been applied to the clinical field because there is a lack of understanding of the basic physiology, and there is considered more of my opinion and your opinion. But there is our actual physiological concepts out there which we need to understand. We have long moved away from the aesthetic type of training, building the body muscles, and we have more concentrating on the functional strength and neuromuscular efficiency type of training, for which we have started doing multi-joint, multi-planar, and proprioceptively enriched approach. But even though we are trying to do this for giving a more functional strength, what is the meaning of that? Whatever we are doing in the gym has to be translated to the daily life. Now, this has become our main goal for exercise therapy now. So even before starting such a treatment, to have a controlled movement, we should have mobility and stability. Then only we can move to this even type of therapies which are going to give for controlled movement. So we need mobility and stability first. So for practical purposes, how to define stability and mobility? If we take the movement of knee joint, what is the meaning of stability? We should be able to move the knee joint, the flexion and extension, without any undue movement in the lateral ways in case of knee joint, which can lead to injury. That will be considered as a stable joint. And what is the meaning of mobility? We should be able to move the knee joint to its full range of motion without any restriction. That will be considered mobility. So this is clear what is stability and what is mobility in an exercise physiologist point of view. But the problem comes if we ask to stabilize a joint. We can try ourselves. If you want to stabilize a joint, what we are going to do? Automatically, we will contracting both agonist and the antagonist muscle, and we will try to make the joint immobile. So if you want a more stable joint, it will become immobile, and if you want a more mobile joint, its stability will be compromised. So it will be like a balance between stability and mobility. But for our day-to-day life, we need both. We need a stable joint which has a proper mobility. Nature has given us components for various segments of the various joints. Each has been specialized for either mobility or stability depending upon the requirement. As we can see here, the ankle, hips, thoracic spine, and the glenohumeral joints have more mobility component than the stability component, while the foot, the knee joint, lumbar spine, and scapulothoracic region have more stability component than mobility component. So physiologically, we need both mobility and stability, but each should not compromise the other. As logic serves, if we have to have a proper movement, we need a stable joint. Okay. So when we need a very stable joint, it becomes immobile. So we are now going for the balance between the two. As we can see here, both are alternating. Foot is stable, ankle is more mobile, knee is stable, hip is more mobile, lumbar is stable, thorax is more mobile. This alternative arrangement of stability and mobility components helps us to move better. It gives us the optimal movement. Okay. Coming to this is not only there's an alternate arrangement, but each are interlinked. When there is a problem in one joint or one place, it can affect the other place also. Now I'm introducing the concept of kinetic chain, which has long been told, but for this purpose, I am just giving a small introduction to it. To experience what is kinetic chain. If you try to push a wall, the movement has to come from our shoulder joint and the elbow joint. That is enough. But when we are trying to do that, what happens? We unconsciously contract or generate tension in our core muscles also, and the tensions are developed in the leg muscles too. This is done to prepare our body to not falling from backwards. Why I'm telling this is, when you are doing a movement, it has to be supported from other regions also for the optimal movement in one joint. Even far away regions has to act normally so that we can do a simple movement. To further emphasize, this linkage is called as kinetic chain. To further emphasize, let us go into an overhead dumbbell movement, which we are trying here. If I have to move the dumbbell above my head, the force has to be generated from the foot, which has to travel through the ankle, knee joint, hip, lumbar, thoracic spine, glenohumeral joint, elbow joint, and to the wrist joint also. If there is a problem in any one of this, then I will not be able to perform this simple action. This concept is called kinetic chain. There is a relation between each joints. If there is a breakage in any one of the place, I will not be able to do this concept. Few of the authors have expanded this kinetic chain concept and have told that it is the link between nerve, muscle, skeletal, and connective tissue also. So the kinetic chain has been linked to the other systems also. It's not only the musculoskeletal system on the various joints. The kinetic chain can be expanded to include the nervous system, from where the signal comes to the musculoskeletal system and to the connective tissue and fascia also. So these are the very basic concepts with which I want to proceed forward. Now coming to stability, there are more than 230 joints in our body. So what is more required is the stability. If the stability is not there, then it will lead to trauma. So what type of trauma? This is the macro trauma, which you are all know in sports injury. When the external forces overcome the normal stable components in the body, that is macro trauma. This you are always know about it. But I want to tell about the micro trauma. We have seen individuals who are having this slightly turned foot. When walking also, they will be walking in the same manner. What is the problem in it? This is a normal knee. He has no injury, nothing. But when the foots are aligned like this, what happens to the knee joint? For flexion, normal flexion and extension during walking, the alignment is not in the correct line. It is slightly tibia is externally rotated, and the knee joint, the congruence in that is deviated. So what happens? There will be a small stress, which is not going to create any pain and all. But what happens over weeks? What happens if this continues over years? Okay, so this small amount of stresses gets accumulated over time that can lead to injury at a later point. This is the micro trauma. So this is a big challenge which has to be addressed. Okay, how we are going to proceed with that? So if we have to stabilize this and correct this, we have to know about the various stability systems in our body. So we are having 4 basic stability systems: passive system, active system, control system, and actively passive system also. So till now, what I have seen is that what is the importance of stability and mobility. If there is lack of stability, then it can lead to injury. Now we are moving through this section where I am discussing about what are the various stability maintaining systems in the body. This passive system is very clear, which you all know, is the anatomical structure. The basic anatomical structure will itself give the stability to the joint. This is very clear when you are going to compare a shoulder joint and a hip joint. In case of a hip joint, the femur head is placed deeply into the acetabulum. So it is more stable. As we can compare to the shoulder joint, it is just gliding over the glenoid. So as compared to hip, the shoulder joint is not stable. But what is the benefit of that? It provides more mobility. So the stability given by the anatomical structure, that is the bone structure, forms the passive system. Not only the bone, the joint capsule and the ligaments surrounding the joint will give stability to the joint. This forms the passive system. Next comes the active system, the muscles involved. If we are sitting here and we ask to stabilize the shoulder, automatically what we'll be doing? We'll be contracting the anterior and the posterior muscles also, both the front muscles and the back muscles will be contracting together. The co-contraction of the muscles will stabilize the joint. So whenever we are thinking about stabilizing the joint, the muscles are involved. So active contraction of the muscles will also provide stability to a joint. So this forms the active system of stability. Not only these major muscles, there are locally placed muscles. In case of vertebrae, there is multifidus, and this case of shoulder joint, subscapularis are there. So these muscles which are located very close to the joint will contract and provide stability to these joints. Whatever happens when you are trying to do exercise or training in the gym, we'll be more concentrating on the externally visible muscles, pectoralis major, biceps, and triceps, but we will be missing to train these locally internally placed muscles, which can lead to injury. So when you are training, we have to give concentration about these muscles also. So that will be the concept. Now coming to the control system. Now what is this control system? Control system stability is given by the nervous system. How a nervous system can give stability to the joint. So to understand this, let us see a scenario. A person is trying to deliver a heavy weight to us, and we are trying to receive it. When you are trying to receive it, what we are actually trying to do, if you imagine that you are going to stretch your hand and going to receive the weight, automatically what we'll be doing is we will be stiffening our elbow and stiffening our shoulders and stiffening our trunk muscles so that we anticipate the weight and we accommodate to that. So how much amount of tension should be developed and what are the muscles should be contracted? This is done half consciously, but most of it's done subconsciously also. So nervous system plays an important role in activating the necessary muscles to give stability to the body. So this is slightly difficult to follow, but now let us give me this example. If you're walking in a dark alley and you're suddenly facing with a small obstacle and you're stumbled upon that, immediately your body is correcting to that and it is preventing you from falling. Here we have to remember that you are not consciously contracting which muscle to be contracted so that I will not fall. It is happening reflexively. So here we can understand the importance of the nervous system. The nervous system gives unconscious stability to the system. So not only the active contraction of the muscles, which we do consciously, but unconscious contraction of the required muscles, which is taken care by the nervous system, also provides stability. So this forms the third part of the stability system. Coming to the last one, the actively passive system. Here we are talking about the fascia. There was a good talk which was done yesterday, Myofascial Meridians. My concept is also just an extension of it. This actively passive system talks about the fascia, which is covering our entire body, the deep fascia and the superficial fascia, which is covering the entire body. Previously, it was thought of like it's just a connective tissue providing support, but it has more role than that. They have found that the fascia is having mechanoreceptors. These are specialized sensory receptors which can sense tension, which can sense pain, stretch. So these can give active feedback to the nervous system and it can correct the muscle activation also. So fascia is not passive, but it's also active. Now it has been found that they also have myofibroblasts. So even the fascia can contract. They actively interact with the muscles to provide stability also. So hence they have been told as actively passive system. Now we have a doubt how just a covering can give stability to a system. The concept of myofascial meridians and discussion about this is beyond the scope of this talk. So I want to just introduce to the concept of tensegrity. Fascia is able to provide integrity to a structure based on the tension generator. Let us have a look at this diagram. The brown wooden sticks, the lower portion and the above portion, which are not in contact with each other, but the structure is maintained. The structure is maintained by the relative tension generated by the wires alone. There is no actual contact between this. And the structure is maintained by the compression force created by the tension in the wires. Okay. In the second diagram also, these sticks, the small sticks, are not touching each other, but they are connected by minute elastic wires, which is maintaining the tension in the system. We can imagine that these rods are like bones and these wires are like the fascial line connections which are present there. Okay, so the structure is maintained not by direct contact like physical skeletal joints, okay, but the structure is maintained by the tension, the stretch force and the compressive force generated by the wires. Okay, so this is tensegrity. The integrity of the structure is maintained by the tension. This concept is even used by NASA for delivering satellites to the Mars also, so that the system can deviate and then come back to normal. So what is so special about the system? Here you can see that if we deform the system, it will come back to normal again. So it provides some form of stability, but allows mobility also. As I have discussed earlier, each and every joints need some support, but it should not compromise mobility. So here is a system which can provide mobility. It allows the movement, but it brings back the structure towards normal also. So this is exactly what is expected. So the physiological fascia system is providing us with this tensegrity. And various models has been generated to replicate how fascia can help in maintaining the stability, called biotensegrity models. This QR codes which I have given are scannable. If you scan this, you can go to the corresponding website to access the same. So this is about the tensegrity. So what are the systems we have seen till now is a passive system. The actives given by the anatomical structures, the bone structure, the connective tissue. Okay, the active system given by the active contraction of the muscles surrounding the joint and the local muscles. The control system, that is a stability given by the nervous system, that is unconscious stability given by the nervous system. The fourth is the actively passive system, that is provided by the fascia, which is covering the entire body. So these are the four stability systems. Now, how to assess the stability and the mobility? Before working on that, we have to assess whether it is stable or if there is any compromise in the mobility. For that, we can assess a simple standing posture. That is the role of posture in assessing the stability and mobility relationship. If the stability and mobility relationship are altered or changed, okay, then it will be getting reflected in the normal standing posture itself. So even by assessing a normal standing posture, we can get an idea about stability and mobility relationship. Okay, the static posture is the reflection of the muscle imbalance and the neuromuscular coordination also. Okay, let me explain what is muscle imbalance. To start with, I am starting with a simple joint, the elbow joint. In elbow joint, the normal movement we expect is the flexion and the extension. Even for this normal action to happen properly, there should be a balance between the biceps and the triceps. If the biceps is contracting more, the flexion may be easy, but the extension of the elbow joint will become difficult. So we can understand that there should be a muscle balance between biceps and triceps for the proper mobility at the elbow joint. Okay. Now, let us come back to Mr. Kumar, who's been sitting in this desk job for longer duration of the time. Let us look at his trunk muscles, the anterior chest muscles, what you can observe there. He's sitting with the curved posture. His anterior chest muscles are shortened. What is happening to his back muscles? The back muscles are lengthened. Both will lead to weakness of the muscles. Okay, why there is weakness of muscles? To understand this, let us go back to the basic MBBS physiology which you are learning. Each muscle fibers is made up of sarcomeres, and the interaction between the thick myosin filament and the thin actin filaments is helping to generate the force. Okay, when we have a length tension relationship curve, okay, the 100% in this graph, the x-axis shows the length and the y-axis shows the tension generated, that is the force generated. This is the 100% is the normal resting length in an individual. Okay, in the normal resting length, the force generated depends upon the interaction between actin and myosin. How much overlap is there? How much overlap is there between the actin and the myosin filaments? Okay, the normal resting length, if we slightly stretch, the interaction between the actin and the myosin increases, so the force generated also increases. This is what we are learning in Frank Starling's lab. As the length increases, the force of contraction will increase, but within the physiological limits. If you extend the length more, the interaction between the actin and myosin decreases and the force generation will reduce. Okay, so the force generated by the muscle depends upon the interaction between actin and myosin. Now, coming to the opposite end, if we go less than 100%, what is going to happen? Again, It is overlapping too much, but the interaction between actin and myosin is also again less. So the force generated by the muscles will be less. So what is happening to Mr. Kumar is that the back muscles are lengthened more than normal, and the front anterior muscles are shortened less than normal. So both the muscles are now weak. Now why I'm detailing about this physiology again and again, why I'm spending so much time on that. Now what happens is that our body is a great compensator. It sees that in this hunched back position where he's doing the desk job, the muscles have become weak. Now body will try to compensate for this. How? It will compensate. It has to increase the strength in this newfound length for the anterior and the back muscles. How it will do? It will change the length of the muscle itself morphologically. In case of anterior chest muscles, it will lose sarcomeres in series. In case of back muscles, it will add more sarcomeres in series. As in this diagram, what you can see is that the curve itself will be shifted to left. The anterior chest muscles, which are shortened, will lose the number of sarcomeres in the series and will become short, so that the force generated in this newly found shortened length will be more in anterior chest muscles. In case of back muscles, more sarcomeres will be added in series, and its resting length itself will be changed to this new elongated length. So the force generated at this elongated length will be more. This is the compensation done by our body. This is not going to happen overnight. This will be happening over weeks, months, and years together if you are continuing the job. That's why I told this is one form of micro trauma which you are giving to our body again and again, and the body compensates for that, and it is creating an imbalance. Now it's creating an abnormal balance between the anterior muscles and the back muscles also. So this is the muscle imbalance created by poor posture. So what is the problem now? Okay, because of this poor posture, and we have told that all these are linked. That's the importance of kinetic chain. When there is poor posture in the shoulder, okay, the scapulothoracic region is not able to provide proper stability because it has been hunched forward. And since it is hunched forward and the shoulder is rotated forward, the glenohumeral joint will not have proper mobility. Even though the body tries to compensate for increasing the force, the alignment of the joint itself is wrong now. Okay, so now this blue shirt, the person who is showing the bat, this is how the forehand in the tennis is played. There should be a proper extension at the shoulder joint, which has to be followed by the elbow joint and the wrist joint. Even the trunk rotation has to be done for the proper execution of this. But as you can see this in the old person who is doing the tennis shot, what is happening there? His anterior chest muscles are weakened. So there is no proper extension of the shoulder joint. For generating the enough force, now this force has to be brought from the elbow joint. So that is the problem which is happening in Mr. Kumar. So since there is a proper improper balance in the muscles in the shoulder joint, the force that is required to generate to play this forehand has to be now compensated either by the elbow joint or by the thoracic spine and the trunk. So both elbow joint and the thoracic spine will be stressed more. And if the stress is continued, it will lead to pain. And the corrective exercise physiologist point of view is that we think this is the major cause for recurrence of tennis elbow to Mr. Kumar. Okay. Now, and the corrective exercise physiologist have given exercise to him. Stretch the muscle. Okay, the anterior muscles which are shortened has to be stretched, and the posterior muscles which has length has to be strengthened. This is basic. We all know that weak muscles we are going to strengthen, and the shorter muscles has to be stretched. But what is the problem in here? Mr. Kumar has done this for 2 weeks, but he's not getting the proper result. The posture is not correcting it. The posture, this exercise is not able to correct the posture. So what is the problem? What I think for this patient is that he's doing the stretching exercise in the gym, but how long he's doing it? He will be doing for 15 minutes maximum, but he's continuing his desk job, which he's doing for 12 hours. Now, if you compare these two, which will be more effective? this hunchback posture, which is doing it for 12 hours, or the stretching, which is doing for 15 minutes. Definitely the stretching is going to give the benefit, but the benefit will not be enough. That will not be enough to correct the entire posture if he's going to continue this poor posture at work. So there are various modalities. He has to change the posture in which he is going to work. Okay, how he is sitting, how he has to position the table. That is called occupational correction, corrective exercises. Then for few people, we may also suggest the shoulder brace so that it stretches the anterior muscles and bring the position back to normal in the shoulder joint. For few people, this also has helped. The third is, if unavoidably, even though we are trying to change and doing the work for long duration of the time, we have to take a break. For every 20 minutes, we have to check our posture and take a break for that. But the most problem is that when you are considering taking a break, we again sit with the mobile phone and hunch back and look at it. So we are again and again facilitating this poor posture. Taking a break means leave, stop the screen time, stand up, have a walk, correct your posture, and then have a little stretch during your working time, and then come back to the work. This will help you more in correcting the posture rather than doing only 15 minutes of stretch. He has to combine both of this to get a most benefit to correct the posture. Now, for few people, we have noted that there may be pain generated. The anterior muscles will be hyperactivated. When he is playing and he's trying to pull the muscle in the shortened position, there may be pain and the fascias may be altered. The facial structure may be altered. So for those subjects, we have tried for giving self-myofascial release, as we have seen here. Okay, this will help in relaxing the facial tissue so that the stretching of the muscles can be done properly. So this also will be helpful. But each therapy which you are suggesting the subject will have to be depend upon that individual. Okay. Now, in the corrective continuation, we have done for the stretch of the anterior chest muscles. Now we have to go for strengthening of the back muscles. Yes, he has done it. He has done it diligently. But why the posture is not corrected? It's not only about the stretch. He has done it correctly. So what is the problem in this? He has told that he has done it very enthusiastically and he has done with heavy weights. Now we have to come back. What is the type of muscle fibers he has training with? There are two types of muscle fibers, type 1 and type 2. We know that for forceful active, we will be using type 2 muscle fibers. For postural maintenance, which is fatigue resistance, which has to maintain the posture for longer duration of the time, we require type 1 muscle fibers. As he has told, he has put weight for long duration and he is stretching and forcefully pulling it. He has inadvertently training the type 2 muscles while he has failed to train the type 1 muscles, which is required. So we think that this may be one of the problem why his back strengthening exercise is not working. This is one of the problem. So what we can do for this? We can reduce the weight and go for endurance type. For muscle health, we have two types of training, muscle strengthening and muscle endurance. Both are different. The training components of these things will be different. In strengthening component, we'll be concentrating mainly on the weight, the amount of weight. The endurance component will be concentrating mainly on the repetitions, the volume of it, how many times and how long. So we believe that if he has changed his technique from muscle strengthening to muscle endurance, which will be concentrating mainly on type 1 muscle fibers, it will be really helpful for him so that it will have help in correcting his posture. Second, as we have discussed, if he is continuing this posture for years together, so what happened is that his muscle length itself has changed. So now we have to make the nervous system and the muscle to learn what is the normal length, and he has to develop the strength in that length itself. And he has to do it in type 1 muscle fibers. So what he can do is, we can ask Mr. Kumar to pull it and hold the position for longer duration of the time. So holding it in isometric contraction will help him more in the required length. where the back muscles has to be in normal length, in good posture. What will be the length? In that length, pull it and hold it. Okay. The second is, as he has told, he has done it forcefully and with enthusiasm. We used to tend to do that. The hand will go forward for full range of motion, and then we will pull it back to the full range of motion. What is the problem is that his length is changed. So his fourth generation capability is shift to the new length. So when he's trying to pull with the maximal weight, where he can pull in the poor posture, which he has been doing while sitting, in the same posture only he can pull, because now the muscle is active and his fourth generation capability will be more in this new wrong lengthened position. If you are going to do in this position and you are going to try to pull it, then you are again going back to this poor lengthened position, and you are training in that lengthened position. So what has to be done to correct this? Start short, keep it in the correct posture and pull it only what is required, and stop short. You don't have to go to the full range of motion. Okay, by doing these three alterations, training for endurance and not going for the full range of motion and holding it in the correct good posture, these type of strengthening exercise and endurance exercise would have helped him more in correcting the posture. So these are the basic physiological concepts which is required before addressing this problem. Okay, again, this is doing in the gym, but it has to be correspondingly corrected in the occupation also. As we have discussed, braces may be required, and he has to correct his sitting posture also while during the work. Coming to the second component, till now we have discussed about muscle imbalances and how to correct it. Now we are going for neuromuscular coordination. Now, what we have discussed earlier, when you are trying to tie a shoelace, in the beginning we would have thought which has to go where and everything. But after we have been trained, we don't even think what we are doing, but we will be doing that job. Like driving a cycle, when you are trying to begin with which step is first, which is second, how to hold it, how to balance it. But after you have been trained, the nervous system takes care of it. How? It unconsciously coordinates the muscle movement. The same happens in case of Mr. Kumar. He has been in that posture for longer duration of the time, and the muscle length has changed. Now the nervous system learns this new wrong length as the resting length, and it changes all the adjacent, all the supporting muscle systems to work along with this new wrong length. Is the entire coordination, the unconscious coordination that is brought about by the nervous system will adjust for this new wrong position. So what is the problem with this? Why we are separately talking about muscles and nerves separately? If he has corrected by stretching the anterior muscles and strengthening the back muscles, it has been done and he has brought back to the normal position, but the nervous system has to learn again. If he is playing the tennis, even if the injury is corrected or if the posture is corrected, the nervous system has to learn again from the beginning. This is slightly difficult to understand. Okay, let us have an example of knee injury. We can see, we would have seen people with knee injury. When the knee injury happens, their gait would have changed. They would be walking in a different manner during the injury. But after treatment, the knee pain would have disappeared, but you would observe that their gait will not have changed. Unless otherwise they are giving attention to their gait and trying to learn it properly, the gait which have changed during the injury will not come back to normal. So these two components are different. Okay. So this is about the nervous system, which is learning a wrong thing. So the next system, the reciprocal inhibition. This is a concept of reciprocal inhibition. This diagram we have seen in normal physiology or medicine examination. When you are tapping the patellar joint, the muscle spindles are stretched. It gives afference to the spinal cord and will contract the quadriceps so that there will be patellar tendon reflex. The quadriceps is contracted, but there is an extended stretch reflex. The black interneuron will supply the alpha motor neurons of the antagonist muscle, that is the hamstring muscles. This black interneuron is inhibitory. So in a normal stretch reflex, if the agonist muscle is contracting, the antagonist muscle will relax. Okay, I'm oversimplifying it, but this is the concept of reciprocal inhibition. The same neural circuitry used by the voluntarily activation given by the motor cortex, the descending motor fibers, which is trying to activate the quadriceps, will also use this reciprocal inhibition mechanism. If the descending motor system wants to contract the quadriceps, it will automatically inhibit the hamstring muscles for the better movement on the knee joint. Okay, so what happens here when there is a contraction in the anterior chest muscles or lengthening in the back muscles, the contracted muscles are irritated. What is the meaning of irritated? Their threshold to stimulus will be very, 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 very less. So all of us are sitting there. I ask all of you to try to do this triceps contraction. You can try and see so that you can experience what I am trying to tell. You can try and see. This exercise is specifically for tricep joint. Have you noticed the biceps is also contracting? Yes. So why this should happen? So whenever we are doing an unaccustomed work, our nervous system tries to protect the joint and it actually co-activate both agonist and antagonist. So when you are doing this, your biceps will also be contracting and triceps will also be contracting automatically. So let us say if my biceps is overactivated and it is in tensed state and I am trying to do this, okay, the nervous system will have to activate the triceps, but instead of that, since biceps have royal threshold and irritability is more, it will contract the biceps. So if it contracts the biceps, what will happen to my extension? The triceps will not be trained because of the irritable muscles. Again, this is the neuromuscular incoordination, which is bringing about the muscle imbalance again. Okay, because of poor posture, the muscles are getting irritated and the nerve is learning to activate wrongly. So there are two components which are totally different from each other. Now you try again this and now actively think that the biceps should not be contracting and try again this. When you are doing this, now the biceps will not be contracting. If you actively think the biceps should not be contracting and doing it, only the triceps will be contracting now. So we can actively unlearn this protective mechanism so that we can teach the nervous system what is correct. So this is a simple example to understand how the muscle imbalance can give a poor learning to the nervous system, and we have to unlearn that and proceed for the proper learning. Okay. Now coming for the next concept called synergistic dominance. What is synergistic dominance? Let us say for hip extensors, gluteus maximus is the main muscle, followed by hamstrings. Let us say because of poor posture, like Mr. Kumar, who is sitting for a long duration of the time, his gluteus maximus will be weak. If we take this gait cycle, the gluteus maximus around the red color structure and the hamstrings, they are activated during the loading response and the mid stance. Gluteus maximus is in two places. You don't have to know the entire gait cycle to understand this. This is enough. Okay. If the gluteus maximus is not functioning, that function has to be taken over by the hamstrings now. Okay. If the gluteus maximus is weak, even for simple walking, the hamstrings will be activated more. So hamstrings will be overused and it will be overloaded and it will lead to injury. So this is synergistic dominance. When the primary mover of a joint is not working, the synergistic muscles has to overtake that work. So, but the hamstring is not the proper muscle to activate the hip flexors. Okay, is not activate for the maintaining the hip joint. So this will lead to injury. So we have seen that improper learning by the nervous system, the reciprocal inhibition concept and the synergistic dominance concept can lead to injury. Okay. In case of our Mr. Kumar, since the pectoral major is shortened, the other synergist will take over. So we have, when you are giving treatment or training for this individual, we have to keep this in mind. Okay, so this is the flow chart. When there is muscle imbalance, tightened and shortened muscles are there. It will lead to two ways: loss of sarcomere length, which shifts the length tension curves to the left. It leads to lower irritability threshold. So the desired muscle action will not be proper, and it will again lead to muscle imbalance, lead to synergic dominance. It will lead to chronic stress and injury. So all these basic concepts has to be clearly understood to give a proper therapy for Mr. Kumar. So what is in the neuromuscular coordination? His brain already knows how to have a forehand, But because of poor posture, now he has learned a new coordination, which is wrong. Even if we give intervention and change the posture, now he has to learn this technique again, unlearn this bad posture and relearn the original correct posture. Okay, so this has to be kept in mind while giving the training sessions. So coming back to Mr. Kumar, who is having the tendinitis, the acute management will be the same, and the correction of underlying causes by corrective exercise will remain the same. But in addition to that, we'll be adding what type of exercise, what is the mode of exercise, and the concept of learning and unlearning in neuromuscular coordination has to be kept in mind to help him better. Okay, so by this, I am completing my talk. Thank you very much for giving this opportunity. Thank you.
Thank you very much, Senthil, for
Thank you, madam.
wonderful presentation.
Thank you very
I
much, madam.
think we should all apologize. I think all the entire audience, we are all sitting in a faulty posture. So first of all, you have to let me correct my posture before I give my concluding remarks. So to summarize his presentation, he first introduced the concept of kinetic chain, which is basically deals with the study of the human movement. And he says how posture means an important part in day-to-day life, because faulty posture may lead to musculoskeletal dysfunction, and in the long run, it may lead to injuries. So development of a better stability is essential to maintain day-to-day activities, but it should not compromise mobility and vice versa. So this corrective exercise physiology actually deals with addressing these two issues. Here also, he said, first, we should get trained for mobility, then followed by stability. In mobility, he said myofascial stretching, release techniques, and in stability, we have to mainly focus on training on the type 1 muscle fibers, which are the main posture regulating muscle. And finally, he concluded with corrective movement, which actually integrates these two components. So thank you very much, Dr. Senthil, once again for enlightening and awakening us how much important is posture, because when I am sitting and relaxed doing nothing, most of the time I feel whichever comfortable position I am better, so I should continue with that. But now it says that even at rest also, I have to maintain a proper posture so that my muscle and the entire system does not get dysfunction. Thank you very much.
Thank you.
So I think we can go for questioning from online speakers. Okay. We have one question from the online participant, Dr. Senthil.
Yes, madam.
Yes. Thank you, Dr. Subramaniam. I loved your talk.
Yes,
I've got two questions.
Yes, sir.
The first question was on a concept I've learned since yesterday only.
Yes.
The role of the fascia. The
Yes,
fascia,
yes,
superficial fascia.
Yes, sir.
I'm a neurologist, so I wasn't aware of this concept at all, of the tremendous role the fascia plays.
Yes,
the
sir.
question is, you talked about two concepts. One is the micro trauma.
Yes,
that is a safety mechanism, a corrective, restorative mechanism.
Yes.
What level does it take place? In the fascia level as well as in the muscles, or in any one of them? That's one. And what is the physiology of receptor population within the fascia? For perceptive receptors and what types, and pain receptors and what types? Because clinically we have the myofascial pain syndromes.
Yes, sir. Yes, sir.
Fibromyalgia and all these concepts, which are not certainly what I do, but in the pain patients,
yes, sir.
I think I can understand their symptoms better.
Yes, sir.
After your fascia discussions and yesterday's planes of body.
Oh, yes, sir. Meridians.
So that's the first question
Yes,
about
sir.
the fascia. Please elaborate a bit.
Sir, first I will address the microtrauma, which I have been discussing. This microtrauma happens at all the levels, sir. Depending upon what type of poor posture we are maintaining, it will happen at fascia levels also. It happens at ligament level, it happens at muscle level, and it happens at bone level also. So microtrauma happens at all these levels, depending upon what type of imbalance we are creating in our day-to-day life. So that is one form. I think that's the first question you have asked. And for the second question, sir, the facial components, There is a study which is done here. The histological study of deep fascia of the limbs. The QR code which I have given, we can scan and go for it, sir. And here they have given in detail what are the type of receptor which are present in the fascia and how it is helpful in our day-to-day life also. They have discussed on that topic. And as I have told during my talk also, it has the mechanoreceptors, mainly the stretch receptors and pain receptors are more. And they have told that these informations gives the proprioceptive information also. So the fascia is giving proprioceptive information, stretch and the fourth generation information and the pain information. These are the three receptors which has been recognized till now coming from the fascia. And this is a reference so that we can go back and have a look on that, sir. Yes, sir.
Yes, I mean, this is new to me. I'm not sure how long physiologists have been doing all this, but I've been out of this touch with this area. Is it a new field in the last 2 or 3 years, or is it 10 years?
Sir, the talk on the fascia started even for 15 to 20 years before also, sir. But the reasons, because it's the study itself, the receptors on study is in 2008. That itself is more than 12 years before. So physiotherapist has been talking about fascia, but only recently now the scientific concepts have been added to that. The trigger points have long been known for even 20 to 30 years before also, sir.
The rheumatologists have been studying the fibromyalgia
for even long duration. Yes.
So 96, 94,
yes, sir.
Before that I was doing
yes,
number of points along the back lines. Now the
yes,
relationship
myofascial trigger points, sir. Myofascial trigger points.
Myofascial trigger points and number of points and diagnostic value of all that.
Yes,
so thank you for that. So when you said micro trauma
yes,
of the bones, that is a bit worrying because it is just a minor micro ruptures what we do in dry needling often to heal the process, just artificial iatrogenic inflammation to release cytokines and local chemokines to promote healing. Is that what is happening? Micro trauma, principle of micro trauma?
No, sir. The way in which we are dealing with the patient is not up to that level, sir. I will be considering mainly on when the person is walking in the knee joint, he will be having the problem in the meniscus. The meniscus which is in between the two bones, which is getting damaged. So I have seen more of that type, and the inflammation in the meniscus will be there. And they will give a history that don't have any injury. I am simply leading a daily life. Suddenly one day morning, I have got injury in my lateral knee. Why it is paining now? I have dealt with more such type of pain rather than the bone injury itself directly. But I have studied that this microtraumas can even affect the bones. But I have seen more such type of microtraumas rather than the bone ones.
Is this research quite prevalent in the Sports Authority of India, in our Olympic elite sprinters?
Yes, sir. Yes, sir. Yes, sir.
They're doing research in all these areas.
Yes, sir. Yes, sir. Yes, sir.
And there are papers you can.
Yes, sir. Papers related to that, sir. Yes, sir. Definitely, it's yes.
The second question, if time permits, is about Mr. Kumar. I like the way you explained everything. It makes good sense for us sitting on chairs for 12 hours.
Yes.
Now, what is the time taken to learn? To unlearn the bad habits and to relearn the circuits. What is the dose? How long does it take?
Yes,
and we saw Djokovic's stance and the senior citizen stance, clearly different. So I just want to know about the neuronal plasticity and the microtrauma and the recircuitry that takes place, how time interval.
When looking at the literature, sir, even the morphological changes in the muscles, there are, as I have discussed, there are two things has to be changed. One, the morphological change in the muscle, and the learning in the nervous system. There are more research on the changes in the muscle now, till that also in animal studies only. How long it will take for the sarcomere length to change? Not if the addition of sarcomeres is sarcomerogenesis. Instead, the sarcomere length itself can be changed. There is a recent study in 2021. They are changing, the number is not changing, but the length of the sarcomere can change. But the change can happen even within 2 weeks, 2 to 3 weeks. So that is about the muscle training. For neural training, it depends upon the effort given by the subject. It is more subjective. So how much the effort is given by the subject, depending upon that, the time duration changes. And the scientific literature on this is slightly varying, but it also has the same duration of the time. So from starting from, as is like learning a bicycle, few people learn earlier and few people take weeks or more months to learn also. So it has become more subjective now rather than giving a clear-cut definition for it. If I have tried and when I have seen a patient, it has took me 3 weeks for giving him to change, even to if the person was walking with this, I have tried to change the posture. For it took me 3 weeks to even to make him to walk in straight foot itself, to learn even without any injury, for them to learn. That is the minimum amount of time I'm talking, sir. It for few people it takes even more.
You said 3 weeks.
Yes, sir.
That's for the adductor.
For them to automatically, without consciously placing it, he has to place it. For that to happen, it took for rigorous training from morning to evening. If he is consciously doing and training, it took me 3 weeks to unconsciously for him to bring the foot. But that is the shortest duration I'm telling, sir. But it may take even more also.
Good way to study with fMRI brain and
yes, sir, yes, sir.
Do neuronal mapping to see what's happening at the supraspinal level.
Yes, sir.
For changing the gait cycle, gait lab.
Yes, sir. My next research I want to do in that, sir. We have a gait lab in AIIMS Mangalagiri, which is under physiotherapy department. So I want to have a collaboration and go with that. How the training and helps in that way.
With fMRI.
Yes, sir. fMRI is also there. Yeah.
Yes. So thank you very much.
Thank you, Dr.
Thank you, sir. Thank you. Thank you, madam. Thank you very much.
Once again for your presentation, and because of the time factor, we are ending up the questioning session here. If any one participant is having any doubts, they can send the question to the organizer. It will be mailed to the concerned speaker. Thank you very much.
Thank you, madam. Thank you very much.
Thank you, Dr. Sendal. It has been a pleasure listening to you. I must confess that Dr. Sendal could not come straight because he had some physical problem. You can see him actually coughing on and off. He had very high grade fever and LRI. He could not come. Thank you so much for joining us online. The happy moment of any conference is to learn something totally new. And you have thought everything new to us. The way we were looking at neuromuscular physiology has now changed. I think it has to be now converted into research. Thank you so much for us. To appreciate your participation in our conference, we would like to honor you with a memento, but since you are online, we have your better half here, so she will be collecting your memento on your behalf.
Yes, sir. Thank you. Thank you, sir. Thank you very much.
Next, we would like to honor the chairperson for this session, Dr. Parmita Bhattacharya. Madam has always been a big support for our department, for our institute, a very constant examiner for our undergraduate students. Welcome, madam. Thank you so much. Now moving on to the next session.
We would now like to welcome Professor V. Gladwin, Additional Professor, Associate Dean, Department of Anatomy, JIBMA, who is here offline with us. I would also like to request Professor Rajshekar, HOD, Sri Venkateshwara Medical College, the chairperson of the session, to speak a few words about our speaker here.
I'm comfortably, no problem. Good afternoon to everyone. I am to introduce Dr. V. Gladwin, Additional Professor, Department of Anatomy, Associate Dean, Academics, JIPMER, Pondicherry. Undergraduate, MBBS from Government Medical College, Madurai. Madurai is very famous. I have worked in the same hospital for some time, 1 year in surgery. Then PG, MS from JIPMER, Pondicherry, from our department, and DPNB, 15 years of teaching experience, published articles, various national and international journals, and research project on hand granted with the 3 lakhs, working on gene of polymerism with maternal THFR gene in birth defects and orofacial clefts. Has got a project, very big project he is working on, and he is a member of many associations, Anatomical Society of India and Society of Clinical Anatomists, Association of Anatomies of Tamil Nadu, International Society of Plastination, and National Academy of Medical Sciences. In addition, for SBV, he has been constantly a research council external expert for our PhD candidates. Thank you.
Thank you, sir. Thank you very much. For the next 40 minutes, maybe I'd like to discuss the role of epigenetics in skeletal muscle adaptations to exercise and exercise training. Basically, I worked only in the genetic area. This epigenetics field is really a new field. We'll touch upon very basic part of this epigenetics in this session, since we do have a mixed crowd anatomist, physiologist, as well as a biochemist. To begin with, so we all know all the cells of human body have the same genetic makeup, but they do appear functionally different, as well as morphologically also they do appear different. During embryogenesis or during histogenesis, the cells gets differentiated to perform various specific functions. So we use the term differentiation. For example, heart cell gets differentiated and it performs its own specific physiological function. And similarly, we do have several types of cells, say for example, a nerve cell or a skin cell, right? But if you see the underlying basic genetic makeup or genetic code, it all remains the same for each cell. But how this happens during embryogenesis or during histogenesis? So for this, we'll just look upon the genetic as well as the epigenetic changes, the basics. So we all know this is the basic structure of this DNA, right? So when we mean any genetic changes in the structure of DNA, so it means the coding regions. So it means the genetic makeup of this DNA, there might be a change. Right? There can be a mutations or there can be an addition, deletion, etc. So thereby this genetic makeup gets changed. So that has led to a defective protein or difference in the production of protein. So this is called as the genetic change. So this, to some extent, I am comfortable with, and most of us, we are comfortable with. So we do have several studies in SNPs, polymorphisms, copy number variations, etc. in these genetic changes areas. So what do you mean by this epigenetics? So over and above this genetics, there are some changes in this DNA sequence, how it has been read and how it has been expressed. And this is called as epigenetic changes. One such example I can just show you in this picture. So here, what you see, the genetic code remains the same. So here, if you see here, there is a change in this genetic code. There is a replacement with the, so G has been replaced with T here. But whereas if you see here, the genetic code remains the same. But in addition to that, there are some chemical groups which has added to this DNA. So which has led to some changes, and these changes put together, they are called as epigenetic changes, right? Over and above the genetic code. Now, so what happens because of this genetic and epigenetic changes? Now, so genetic changes usually results in how a protein is made. So it can result in a defective protein, or it can result in non-synthesis of that particular protein or some other altered proteins. Now, this epigenetic changes can affect how a gene is expressed. So we usually sometimes use the term whether it is switched on or switched off. Right? So whether in that particular cell, that particular DNA sequence or the gene, whether it will be expressed or it won't be expressed. So this is determined by this epigenetic changes. Now, unlike genetic changes, most of the genetic changes are irreversible. Right? So once there is a mutation, it continues to be their mutated one. So, but these epigenetic changes are reversible and they do not change your DNA sequence. but they can change how the body reads the DNA sequence, right? It is reversible, but it can alter how the gene is expressed. So that's the difference actually. Like, so now we do have a same genetic code for all cells, but some genes are switched off and some genes are switched on, right? A nerve cell is intended to do its own function because of the switched on nerve cell related genes. And similarly, the muscle cells perform its own function because of the switched on muscle cell related genes. Fine. So the same mechanism because of this epigenetic difference. So the muscle cells and nerve cells, though they have the same DNA, they work differently. A nerve cell has its own specific function, and similarly a muscle will have its own function. So this is determined by this epigenetics. So the way how the gene is expressed, the mechanisms by which a particular portion of this DNA code is switched on or switched off. Right. So having given that brief introduction about that epigenetics over and above this genetic sequences, so we do have some type of epigenetic changes. So usually, like, we start with this DNA methylation. The first type of this epigenetic modification is a DNA methylation. The second one, there can be modifications in the histone proteins. So because of this modification, there can be a difference in how the genes are expressed. The second epigenetic changes means it's histone modification. The third one, so we also like describe some non-coding RNAs. A type of non-coding RNAs are called as microRNAs. So when there is a change in this microRNA mechanisms, so it also induces or suppresses a particular gene, whether it can be expressed or it can be translated or not to be translated. And similarly, we do have some other mechanisms by which the microRNA can influence the histones. Thereby, indirectly, it can also make a particular portion of a gene to be expressed or not to be expressed. Right. The last one, we call it as epitranscriptomics. Right. So this is again a new field getting into this ones. So how RNA can be modified. So these are the various types of epigenetic changes by which a particular cell is determined to perform a particular function, right? So one good thing about this epigenetic changes is reversible. So that's why, like, some of this environmental influences like dietary habits, exercises can influence all these epigenetic changes, and it will also have its own healthy and beneficial effects, right? So we start with this DNA methylation. So this DNA methylation works by adding a chemical group to this DNA. So usually this is a methyl group, so CH3 group. So typically this group is added to specific places in DNA where it blocks the protein that attaches DNA to read that particular gene, right? So I can just show you one, so how it works. So most DNA methylation occurs on cytosines. These are found in CpG islands. And this will have its own influence in case of whether that particular gene will be promoted for its protein synthesis or not. So usually when there is a DNA methylation, it will suppress that particular gene. So typically the methylation will turn off a gene and demethylation will again turn on the particular gene. Right. So this is a cytosine residue, like this is cytosine. So with the help of this DNA methyl transferase, when there is an addition of this methyl group here at the 5th carbon atom level, so this means this particular cytosine is methylated, and this is called as the DNA methylation. Suppose if you see here in the DNA sequence, so something like this, so it is like schematically marked, and these are the areas which are methylated. So when it is methylated, so there will be a problem in reading that particular sequence. So the DNA code or the genetic code may not be read, and that particular DNA or gene is not expressed, right? So this is one mechanisms by which the epigenetic changes can influence, right? So this is again an example. So this is to show you the promoter region, the CpG island, right? So now this one means it is unmethylated, right? There is no methylation of this particular cytosine residues here. So then it causes this particular gene to be expressed. When there is methylation, so this is a methylated one, and the particular gene is silenced, right? So this is one mechanism by which a gene is expressed or a gene can be silenced, whether it can be switched on or it can be switched off. Right. Now, So the entire this process of DNA methylation is catalyzed by a family of enzymes that is called as DNA methyl transferases. It is called as DNMT, right? So it transfers a methyl group from SAM, S-adenyl methionine, to this 5th carbon atom in the cytosine residue. Right. So we do also come across various types of this DNMTs, that is DNA methyl transferases, namely DNMT1, DNMT3A, and 3Bs. Right. So these have its own role. So DNMT normally regulates a normal methylation process, and this 3A and 3B have its different role compared to this DNMT3-1. Now, so this is how this entire reaction occurs. So this is the cytosine residue. So from this SAM, one methyl group gets transferred to this one. So thereby it becomes a methylated DNA or methylated cytosine residue with the help of this particular enzyme, so DNA in methyl transferase, right? So this process is called as DNA methylation. Now, so what happens? So basically to sum up what happens because of this DNA methylation. So when there is a methionine, so with the help of these enzymes, so they causes methylation of this DNA. And because of this methylation of this DNA, there will be a transcriptional repression, right? So that particular gene will be suppressed or repressed, and there won't be any production of this particular protein component, right? Similarly, what happens? The opposite way. So when you have like 10, 11 transcriptases acting, so when there is demethylation process, the transcription initiation complex gets activated and the transcription activation starts, right? So there can be transcriptional repression when there is a methylation process. There can be transcriptional activation when there is a demethylation, right? Now, so what happens during these exercises, right? So now there are several studies related to this epigenetic changes in and exercises. Many studies are evolving. So most commonly observed changes being, so exercise causes, like whether it can be a acute period exercise or a period of several months. So it causes differences in this DNA methylation, right? So the main changes occurs in this DNA methylation in response to exercises. So here it causes demethylation, so that there will be increased expression of genes, in particular genes specific to skeletal muscles, right? So we do have changes in this DNA methylation in response to exercises, in particularly the genes which are related to this skeletal muscle genes. So there are several studies, though there are some like mixed results. So some areas we do have some hypomethylation, and some of the studies telling that there will be some hypermethylation also in some of these genes. So it all depends upon which particular promoter region genes gets hypomethylated or hypermethylated. So in a nutshell or in an outline, so when we do this regular exercises, the studies have shown that there is an hypomethylation reaction, so which leads to increased gene expression in specific skeletal muscle genes. So that's a response overall in case of this DNA methylation. So DNA hypomethylation in key exercise responsive genes in skeletal muscle is the most established mechanism of adaptation to exercises, right? Right. So this is regarding the first epigenetic change. Coming to the second one, the histone modification. So histones, we know that DNAs are wrapped around these histone proteins, right? So when these histones are tightly packed together, the proteins that read the gene cannot access the DNA so easily. So the genes are turned off, right? So when it becomes an open chromatin structure, when it is unpacked, so the genetic sequence can be read, so the genes can become switched on. So that is the basic mechanisms of this histone modifications. So when histones are loosely packed, so more DNA is expressed or not trapped around a histone and can be accessed by proteins to read that particular genetic sequence. So thereby switching on that particular gene. So this is the histone modification in case of an epigenetic changes. So it all depends upon whether the histones are closely packed or loosely packed. When the histones and the DNA are closely packed, the genes are switched off. When they are loosely packed, when the genes are switched on. Right. Now, so how these modifications of histone takes place? So there can be chemical groups added to this histone proteins. So earlier one, we saw this DNA, it's a methylation, the methyl group got added to this DNA. So here, there are various reactions happening. So it can be an acetylation, it can be methylation, it can be phosphorylation, etc. Right? So widely studied areas are acetylation as well as this methylation and phosphorylation. Right now, so this is just a picture to show you like the different parts of this histone. So usually it is described as H2A, H2B, and H3 and H4. So it will have a central domain. So this is called as a central domain of any histone protein, and it will have a small histone tail. So this is a tail part. Fine. Now, so two domains, a central region and the tail region, it is called as a histone. So this tail region will undergo this post-translational modification. So that will affect, or that will have an influence in the chromatin structure and function. So this is a larger picture. So this is the histone central domain. The black color, what you see is the DNA strands, and these are the histone tail. So this is an example, the H3 and the H4. And the tail, you can see the different parts of this tail with different addition of different groups. Like you can see this methyl group attached, the acetylation, phosphorylation, etc. in case of this histone tail. Fine. Now, so what is this closed and this open chromatin structure? So how it works out? A closed or condensed chromatin structure is a result of strong electrostatic interactions. So we all know the DNAs are negatively charged, right? So this histone proteins are positively charged. So thereby they do have a static forces which binds this DNA as well as this histone proteins. So then they become really closed and it will be switched off. Now, any alterations in this histone protein charge through post-translational modifications are sufficient to disrupt this interaction with this DNA, resulting in an open chromatin structure, right? For example, if there is an acetylation of this histone tail, so then the positive charge of the histone proteins will be neutralized. So thereby the interaction between the DNA and the histone proteins won't be there. So it becomes an open chromatin structure, thereby that particular gene will be switched on. So this is a schematic picture to show you like how this DNA and the histone proteins, they interact. So when it is an open chromatin structures, you can see this, the histone proteins, and these are the DNA strands. So this DNA strands are available for reading. So this will be read and there will be a transcriptional activation. So when the histones and this DNAs are closely packed, so these DNA sequences are not available for reading, and then it becomes a closed chromatin structure, and there is a possibility of transcriptional suppressions, right? So this is the mechanism by which the histone modification can result in epigenetic changes, thereby influences whether a particular gene can be switched on or switched off. So the most important post-translation modifications are, as I mentioned earlier, so it's the acetylation, methylation, and phosphorylation. So these are the three most common histone post-translational modifications, right? So now, transcriptionally active euchromatin. So euchromatin, wherever you have an actively protein synthesizing cells, have high levels of acetylations. So because of this high levels of acetylation, the positive charge of the histones are suppressed so that it becomes an open chromatin, thereby the genes are expressed. Fine. Whereas a transcriptionally inactive heterochromatin have low levels of acetylation. The converse is also true. When a particular cell or a heterochromatin part or a cell is inactive, so then there'll be low levels of acetylation and high levels of methylation, right? So methylation suppresses acetylation, so it facilitates protein gene expressions. Now these acetylations, so we saw that DNA methylations are like facilitated by DNA methyl transferases. And similarly, for this DNA acetylations, we do have a group of enzymes called as histone acetyl transferases, so HATs, right? So this will facilitate acetylation. And similarly, we do have another group of enzymes called as histone deacetylases. So in a particular cells, there should be a balance, or the ratio depends. So between like facilitation to acetylation or suppression of acetylation. So this ratio will determine whether how much of that particular genes will be expressed or not. So the relative levels of histone acetylation are determined by opposing enzymatic activities of HAT and HDACS, right? So this is how it works. So same histone protein. So now you have two different enzymes. So one enzyme, it facilitates acetylation. The other one, it suppresses acetylation. So depending upon which one predominates, the particular gene will be expressed or it will be suppressed, right? Now, this is not that simple. So there's something called as an histone code. So now, suppose in case of acetylation, it can be either followed or preceded by so many other changes in the histone bodies, right? So this cascade of events is called as histone code, right? It is not that very simple like acetylation, a global acetylation or acetylation at a specific site can lead to as many changes. There can be a sequence of events. There can be a cascade which causes so many changes in this histone post-translational modifications, right? So it means it's a set of modifications undergone by histones and read by effector proteins that initiate biological responses. So it's a sequence of events in the histone leading to all these modifications. Fine. Now, so what happens like because of these histone modifications and exercise? So what the study says, and this again, just to show you like this methylation and acetylation reactions which are attached to this specific regions of this histone tail. So say for example, so K9, so this K18. So these are some of the things that are widely studied. Now, so because of this functional changes now, so when you have deacetylation, so there'll be transcriptional repression. So when you have acetylations because of this HAT enzymes, with the help of acetyl-CoA, so you have transcriptional activation. So this is the basic things about this histone modification related to this epigenetic changes. Now, in case of exercise and the histone modifications, again, studies have proven that they have come across increased acetylation in this histone tail. So exercise is associated with acetylation of several lysine residues. So in human cells, the histones, they undergo post-translational modification because of this exercise and physical activity. Thereby, there is increased acetylation, increased genetic gene expressions. So that is the main histone modification changes. So that has occurred. So many studies have found increased levels of methylations also in specific histone proteins. Take a note, this methylations leads to suppression, whereas acetylation relates to activation of that particular gene. So it all depends on which genes or which specific genes are suppressed and which specific genes are expressed. Right. So we do have come across several studies, and then you can see this which part of this histone proteins they have studied. So most of this proteins, histone protein studied are either H3 or H4. Right. So the basic key which can be taken from previous studies will be, so there are histone hyperacetylation in key exercise responsive genes in skeletal muscle. So this is the most well-established epigenetic modification post-exercises so far. So one, so there is an increased, there is hypomethylation in case of DNA, and there is hyperacetylation in case of histones. Fine. The third one. So coming to this, what are these microRNAs or non-coding RNAs? So the earlier ones, so they suppress or express from this beginning. That's a transcriptional stage itself. So now there are some group of microRNAs. These belongs to a family of non-coding RNAs. So what's the function of this microRNAs? So usually this coding RNAs, they used to make proteins, right? So from the RNA, so the code is read and you have the formation of this coding RNA. So which will get to form this proteins or enzymes. So now there are a group of non-coding RNAs, in particularly the microRNAs, which will attach to this certain proteins which can suppress that particular translational process. So thereby, though the genetic code is transcribed, during the process of translational process, again, it is suppressed. Or these microRNAs have another role. So this can modify the histone. So either it can facilitate this acetylation process or methylation process. Thereby, it will have an indirect influence in the expression of a particular gene or suppression of a particular genes, right? So that is the mechanisms by which this microRNA functions in switching on or switching off a particular genes, right? So these non-coding RNAs may recruit proteins to modify histones to turn these genes on or off, right? So this is the third epigenetic mechanisms by which changes happens in the skeletal muscle tissues. Fine. A few things about this microRNAs. The microRNAs are small non-coding RNAs that generally repress the expression of several genes. So they form a complex. So through that particular complex, it will suppress the genetic expression. Now, microRNAs arising from the skeletal or cardiac muscles are called as myomicroRNAs. So with this short form, they use this short forms, myomicroRNAs. There are some 7 types of myomicroRNAs they have established. Though some article says there are some 8 or 9. So some 7 types of myomicroRNAs have been established, starting from number 1, 133A, B, etc. So these are the 7 types of myomicroRNAs. So these are the microRNAs which are widely studied post-exercises, either resistant exercises or the endurance exercises, exercise for a short period or a long period of times. Now, so how this one acts? So this is a nucleus, a schematic picture of the nucleus, and this is a cytoplasm area. So now, so there is a formation of this pre-microRNA in this nucleus with the help of some facilitating proteins like DROSHA, exportin, etc. So you have this microRNAs in the cytoplasm. So it will be transported to this cytoplasm. Now, here it forms a complex called as RNA-induced silencing complex. So these microRNAs forms a complex, RNA-induced silencing complex. So this will attach to this reading material, thereby suppress this translational process. So here it suppresses what is called as a translational repression. And this translational repressions are induced by this RNA-induced silencing complex. So this is also one mechanism by which even after a post-transcriptional process, the gene, whether it can be expressed or not expressed. Now, this is an entire sequence of events which happens with this microRNA. So it can have its direct effect or an indirect effect through the histone proteins, right? So direct microRNA cleavage translational repressions or through ribosomal proteins or through histone proteins. So these are various mechanisms by which microRNAs or non-coding RNAs can repress translational process, right? The fourth one. So what happens during this myomicroRNAs and exercises? So studies are coming up. So only we do have studies in only the last decade. So regarding this microRNAs and also the histoproteins related to this exercises. So this myomicroRNAs control several post-training processes. So the basic functions of these microRNAs are determined by means of like some part of or some type of microRNAs promotes myoblast proliferations. So we have learned about some 7 types of microRNAs. So among this microRNA 133A promotes this myoblast proliferation. So there is, it will form a new skeletal muscle cells. So it will facilitate in this formation. And several other microRNAs. So they help in myoblast differentiation, right? So a specific function to this skeletal muscle and how it will make the specific genes related to the skeletal muscle to switch on. And similarly, a few other microRNAs are also associated with this muscle cell fusion, and also they also encourage this muscle cell regeneration post-injury. So these are the various functions of this microRNA post-exercises, which facilitate in muscle regeneration or new muscle formation or muscle differentiations, right? Fine. So now recent studies have also shown that like these microRNAs will facilitate in this muscle fiber shift and also muscle fiber growth. There is a muscle growth hyperplasia in case of post-exercises or post-physical activity, right? Now, so it is also worth pointing out that some of these microRNAs, like microRNA 1 and microRNA 206, have been proposed as biomarkers of endurance, right? So after the endurance exercises, this becomes a biomarker to see that like how effective these exercises are, right? So again, results are coming up. It is in the evolving stage. Right. The last one, that is epitranscriptomics. Earlier, we thought like whatever the changes happening in the RNA are irreversible, right? So latest studies have shown that so RNAs also can be modified, and the changes in the RNAs can be modified. It is reversible. There are some particular proteins which are responsible for this RNA modifications. The widely studied ones are this N6 methyl adenosine. So they call it as M6A, right? So these particular proteins or these specific substances, so they can influence this RNA and can result in this RNA modification. Studies have shown that in addition to this M6A, so we do have some other components also. Say for example, so they have studied this pseudouridine and also N1 methyl adenosine. So they call it as M1A, and few other proteins like M6AM. So it is called as N6 and 20 O-dimethyl adenosine. So these are various other proteins which are also studied. So which can cause changes or which can reverse the changes in this RNA, right? Again, it is an evolving field. It's a budding field, epitranscriptomes, right? So again, it is epitranscriptomes over and above what has been transcribed, right? So we saw genetics, and then over and above the genetics, the epigenetics changes. And here, over and above the transcribed part, we have epitranscriptomics, so which can change this RNAs, etc. So there is nothing is irreversible. So now these are some of the things like which has been widely studied. So as I told, M6A, so for this epitranscriptomics. Now, not much of studies related to this epitranscriptomics as of now related to this exercise and skeletal muscle adaptations, but it's a field so where much of the research can be done, right? Now, so there are several authors, they have described this other RNA modifications, but the articles are not complete in the sense, since this is an evolving areas, so they have not really disclosed all these proteins. So what are the components which specifically modify these skeletal muscle expression or repressions, right? Fine. So they just, they mentioned it has a writers, erasers, and readers, fine. So which can write means which can like modify a particular change in the RNA, which can modify, which can reverse this RNA's modifications, or which can just detect whether the RNA is modified or not. So they just mention it as writers, erasers, and readers in case of this epitranscriptomics regarding this RNA modifications, right? Right. So this is again, it's an evolving one. Not much of data is available in internet, but this is an area for future studies, epitranscriptomics, right? Now, so having said that, like describe the skeletal muscles. So we saw all these changes, epigenetic changes in skeletal muscles after exercises, but not only the skeletal muscles, there are various other non-muscular tissues. There are changes in this non-muscle tissues after these exercises. So example, more than this skeletal muscle, there are changes occurring in adipose tissues and liver. So studies have shown that not only there are epigenetic changes in skeletal muscle after exercises, so there are other organs also involved after exercises. Say for example, adipose tissues, there are a lot of epigenetic changes happening. Liver, also pancreas, brain, and then skeletal muscle. So skeletal muscle we have already we have discussed. So these are the other organs: pancreas, brain, liver, and adipose tissues. So where we do have this epigenetic changes happening after exercises, right? So all these things collectively they contribute to the beneficial effect after exercise. So to sum up whatever we have seen in this epigenetic modifications. So basically, like physiology wise, you do classify as endurance and resistant exercises. We do have several separate studies based on these types of exercises, but we do not have much of concrete data except for these two things. So one is this DNA methylation and the other one is histone modification. So regarding this DNA methylations, we do have a concrete evidence stating that there are like hypomethylations after a period of training or exercises. So because of this hypomethylations, there are expression of specific genes in skeletal muscles having its beneficial effects. And similarly, so regarding this histone modifications, after these exercises, we do have something called hyperacetylation. So that it's hypomethylation, it is hyperacetylation. So which unwinds the histone proteins, Thereby, most of the genetic code can be read and that particular gene is expressed, right? Then the third one, so we discussed about this microRNAs. In case of skeletal muscle, so there are some 7 specific types of microRNAs, and these microRNAs helps in myoblast production as well as differentiation and growth, right? After exercises, there are some specific microRNAs for each facilitating this process. Epitranscriptomics in general, so it reverses the changes in the RNAs, right? So we do have specific epitranscriptome proteins which are widely studied in this particular areas. But again, the field is open for research, right? To conclude, so the impact of exercise on epigenetic modification seems to depend on the type, intensity, and duration of exercises, right? So we do have several studies, but when they take it up as a review, we are not having much number of studies in different areas, gender-wise, intensity-wise, duration-wise. So still much studies we need in this area to explore in detail this epigenetic changes. Now, in the context, whatever has been studied earlier, so we do have evidence stating that resistance and endurance exercise differ in transcriptional regulation in skeletal muscle. So they have found that there is a difference in the resistance and the endurance exercise in relation to this epigenetic changes, right? Now, so as I mentioned earlier, an exciting area for future research will be whether our understanding of epigenetics of exercise can be leveraged to provide therapeutic targets for diseases like obesity, type 2 diabetes mellitus, and other cardiovascular diseases, right? So that will be the future scope of studies in this epigenetic region, right? Thank you.
Thank you very much, Dr. Gladwin. You have done extensive effort studies to prepare this speech for us. And it is usually fascinating, the genetics, but it is difficult to understand, particularly when you go to the biochemical genetics and molecular level, which you have brought to us the details and depicted with the beautiful illustrations.
Thank you, sir.
And the stepwise, the methylation, and then histone, and then micro RNA and transcription, all those things. You have given a lot of, apart from just giving that, you have given a lot of opening. This genetics always is widely growing around like that. You have given that. But I have a question. Generally, I ask what Dr. Mitra used to ask me. I am asking this question. But you have brought to the conclusion, you already brought, it gives a scope for therapeutics for the obesity and other diseases. So with this epigenesis studies, is there any already you have to relieve? It's not a main therapeutic, an additional therapeutics for major illnesses like obesity and diabetes. You have already mentioned. If anything is there, you can tell us.
So whatever I could search, right now there are no therapies available since it's under research. Maybe someone in the audience, suppose if you come across any such therapies right now available, you can just add it on to it. Whatever I could search, it's still evolving areas.
You have given an opening at the end. I was waiting, but it was there in the conclusion in the last.
And even this epigenetic itself is maybe the last decades it's evolving. Personally, we don't have that much practical experience in this epigenetics areas, to be very frank.
But your explanation with the illustrations were very good. Thank you.
I have a question, sir. Dr. Janeth here. As chairperson, thank you for accepting to our conference. As a person who always hits to the gym, and especially during this COVID time, we were not able to do it. But then when again we went there, automatically what we were able to do that, what we were able to observe was like, suddenly the bulk was more, which we were actually trying to get after 2 or 3 months when we initially started. So we call that as muscle memory. So has epigenetics anything or any, or this methylation or demethylation has anything to do with muscle memory, sir?
Yes. So if you see this one, so even in the study says, so this DNA methylations also, like they have seen the changes after a certain period. Say for example, if there is a continuous training, the changes happening in the DNA methylations is not that much significant again. So there is something like registered or something like there is a memory. So it happens over a period of time. So then again, it is reversible. So again, we have to restart.
Is it like any specific duration is there, sir, for it to say like reappear again?
Not really.
Okay, fine. Thank you. We have one more speaker, who has raised his hand online. Yeah. If you can give permission to him, he will.
Yes, thank you very much. Professor Gladwin, yes, I'm very grateful. I think I finally have an understanding of epigenetics through a very well rehearsed discourse. I have a few questions. One was, how does exercise initiate the entire process, be it histone modification, be it DNA methylation, be it microRNA?
Sir, your audio is a little bit down. Can you please increase it?
Can you hear me? Can you hear me now?
It is a little bit feeble.
Okay.
Yeah, now loud and clear. Yes, sir. Thank you.
Okay. Yeah. Thank you very much. I understand epigenetics better now. This was always a vague area for me. Thank you for that. Very good talk.
Okay.
The question I have is two. First of all, how does the exercise process initiate the entire genetic 4 different methods by which there is difference in the gene expression? What is it? Hypoxia? How do the genes get turned on by the process of exercise? That was not very clear in my understanding. So that's one question. And the second important thing was, it was all focused on skeletal muscles. And we know heart failure, including diabetic cardiomyopathy, is a big problem internationally and certainly in India. Heart failure is an epidemic. So how those skeletal muscle studies translate to cardiac muscle epigenetics or cardiac muscle improvement of function? And that's very important. Are they different? So these are the first 2 questions I have for you.
Yes, sir, rightly said. So what are the studies which have shown or which have gone through are mostly skeletal muscle studies. And for cardiac muscles, there are specific cell line studies available. So the basic functional mechanisms almost remains the same, that skeletal as well as this cardiac muscle, though much of the studies related to this cardiac muscles are evolving. So we do have only laboratory studies in the cell lines.
And the first question about what is initiator? Exercise, how does it trigger the gene changes?
So the availability of substrates, and also like suppose like it will have a multiple modifications, as I mentioned. So one is that DNA methylations, the other one the histone modification.
Yeah, but what initiates that? How does exercise cause DNA methylation? Exercise is an activity. Does it, what chemical does it trigger? What's that particular step? Exercise.
Yes.
Is it lactic acid? Is it hypoxia? Free radicals? What initiates that particular process?
So one is that free radicals. So one of the mechanisms, what that was hypothesis was the free radicals, right? And the availability of substrate necessary for these modifications by means of these exercises.
Thank you. I have one more question, if permitted. You said very paradoxically, and that was also reflected by the chairperson, about the lack of long-lasting effect. You said in one of your slides that after the burst of exercise, there is more epigenetic biomarkers seen, whereas after a prolonged time, the effect is much less observed. That's a bit paradoxical in therapy, unless it's a continuous dose effect that is necessary. So nothing is hardwired into the system. The moment you stop exercising, the effect is lost in 48 hours or whatever. And that's the practical understanding. How do we explain it genetically and protein translation wise? Because the protein
That's what's
should
like maybe
persist.
a continuous exercises. So not like over a short period of training. So that's what's like underlying this one. So we need to have a healthy diet and regular exercises.
And going back to the lab, when we have the biomarkers now, as you showed us, the microRNAs, they are being actually analyzed and captured. If we inject these into mice models, if we take the epigenetic biomarkers and inject them into non-exercised muscles, including in human volunteers, if ethics permit, will we see the same effect? Do you see? I'm putting the bench work back into the clinical trials.
Okay, so you are asking, so if we inject this biomarkers into a mice model, whether we'll be having the same effect or not?
Yes.
Okay. So practically, I'm not having that much of this one data or a practical experience to answer that questions. So maybe,
sorry to intervene.
so we need more studies to prove or disprove that particular hypothesis.
The field is being extensive. All these additional thing can be answered in the email or any other digital communication, sir. You're welcome. Thank you. Thank you.
Thank you, Professor V. Gladwin, for the dynamic session and humbly answering all our questions. Thank you, Professor Rajsekhar, sir, to chair the session. I would now like to request Professor Chandra Philip, ma'am, to honor our speaker over here with a memento.
Thank you for accepting our invitation, sir. Thank you. It was a thought-provoking session. It was an outstanding performance, sir. Thank you, sir.
I now would like to call upon Professor Sudha Rao, former HOD Department Anatomy, JIBMA, MGM CRI, onto the dais to present a memento to Professor Rajsekhar, sir.
Moving on to our next session. Now I'd like to invite on stage Dr. Karthikeyan, Associate Professor and Head of Department of Physical Medicine and Rehabilitation, SRM College and Hospital, Chengalpat. I would also like to invite Dr. Aisha Juhi, Assistant Professor, Department of Physiology, AIMS Deoghar, who's joined us online.
Very good afternoon.
I now request Dr. Aisha Juhi to introduce our speaker for the session, Dr. Karthikeyan.
A very good afternoon to one and all. So I congratulate the organizers, ABP ICON, Integrated International Conference Exercise Fitness to Therapy, for organizing an academic fest for all of us. So I'm here to introduce the speaker, Dr. Karthikeyan, for the session Therapeutic Exercises in Rehabilitation. So the current designation is Associate Professor and Head, Department of Physical Medicine and Rehabilitation from SRM Medical College and Hospital. He has educational background of MBBS from Government Tanjavur Medical College, and he has done his MD in Physical Medicine and Rehabilitation from Chidambaram Rajamuthiya Medical College Hospital. He has an experience of 10 years in rehabilitation medicine. His field of interest is basically in neural rehabilitation and spinal cord injury, stroke and traumatic brain injury. He has also very good interest in interventional pain management of musculoskeletal disorders. He also has an interest in management of sports performance and sports injury among abled persons and differently abled persons. He has a total publication that is 5 in national and 2 in international journals. He has a feather of in his recognizations, in awards and recognition. He was a medical lead for Indian Special Olympic Team. He's a goodwill ambassador at Global Rainbow Foundation, Mauritius, for services to persons. I humbly request you, sir, to stick to the timings of 45 minutes and initiate your talk. Thank you.
Thank you, madam. Thanks for your nice introduction. So I assure that I'll try my best to stick with the timings. Right. So the topic is therapeutic exercises in rehabilitation. So I have gone through all the topics since yesterday. So all you were talking about the normal function to fitness. So now we are on the other extreme. Okay. So actually the levels of fitness or levels of function, has these two extremes, that is impairment to fitness. So we are going to discuss about this spectrum from impairment to normal function. So there comes therapeutic exercises where exercises are being used to mitigate to management for the management of impairment and disabilities. So for a normal body function, what we need actually, a joint should be in an anatomical position without deformities, should have complete good range of movements, adequate muscle power to move the joints and the body to function, sustain the functioning of the body, and maintain erect posture with balance and coordination. So this is the basic need of any human being to have a normal function, leave alone the fitness. We are just talking about from impairment to the normal functioning of the body. So just after this introduction, just have a look at this guy. He's a spinal cord. He's a 25 years old person with spinal cord injury. So you can see all the problems. That is, the limbs are deformed and there is a muscle wasting. And when we move, the person will have a complete loss of range. So he is a person who have not undergone any sort of rehab intervention. And over a period of 14 years after his spinal cord injury, he has developed these deformities, and still it is the same with any amount of intervention like Botox or arthrotomy. We couldn't give a much improvement to this gentleman. So what do you mean by therapeutic exercise? It's a planned physical activity performed with the goal to correct impairments, restore, enhance muscular and skeletal joint function, reduce pain, prevent or reduce health risk factors, thereby to maintain a state of well-being. So this is the most comprehensive definition for a therapeutic exercise. So this therapeutic exercise has different domains, that is starting from the muscle performance, cardiopulmonary endurance, mobility and flexibility, neuromuscular control and coordination, stability. So these therapeutic intervention, therapeutic exercise, when we address, we need to have all these in mind. And moreover, when we teach motor task for a person as a therapeutic exercises, we can classify as a discrete, serial, and continuous. Sometimes when the person with an apraxia, it will be very difficult to teach an exercise. When you say a person has kai thukunga, when you ask him to lift, he'll be able to do. The range will be good, power will be good. But when you ask him to do a function or a purposeful activity, he'll not be able to do. So in that case, we have to address that deficiency as these stages: discrete, serial, and continuous. And what are the different stages of motor learning? There is cognitive stage, associative stage, and autonomous stage. A cognitive stage, for example, when you ask a person to learn how to ride a bicycle. So when you give him a cycle, you have to say that. So you have to keep your head straight, keep your spine straight, hold your shoulders in erect. So when you say all these as discrete, it will come to one page. But as you learn how to cycle, this goes automatically. So without your knowledge or without your conscious effort, you are riding a bicycle. After all this, after taking care of all these parameters, what we have mentioned over one page. So these are the different stages of learning, motor learning, that is called as cognitive stage, associative stage, and autonomous stage. So with this background, so I would like to give an overview. It will be a little difficult to give a detailed description of all the therapeutic exercises in different clinical settings. I'll give you an overview of all these basic exercises like stretching, ROM exercises, strengthening exercises, aerobic or endurance exercises, and balance training. And of course, when we say as a person needs a set of exercises, or when we give an exercise prescription, it will be a mixture or a blend of all this. We cannot say this person only need this exercise alone. So a person will have, in this exercise prescription, will have all these in different proportions based on his impairment and his needs. So first we will take up the stretching exercises. Imagine that a person is already having a deformity, then you can't strengthen. So when we say that the muscle is 2+ or 3, it means that he has to move against the gravity and he has to complete the range. When already a muscle or a joint is deformed, even though the muscle is strong enough, when it is not able to complete the range, then it is a deficit. It is incomplete. So in that case, first thing, you have to make the joint in anatomical position so that it has a complete range. So you have to know about what is the difference between functional range of movements and functional mobility. Functional range of mobility is ability of structures or segments of the body to move or to be moved to allow the presence of range of movement for functional activities. Whereas functional mobility is ability of the person to initiate that activity, control or sustain that active movement. So for example, when you say that just you move the hand, he will be moving. But when you want to put it as a sequence of activities, sequence of movements involving different joints, he'll not be able to do that. So the functional range of movement is, in fact, to make it very simple, restricted to one joint, whereas functional mobility is sequential involvement, execution of different joints at one point of time for executing a function. And most of the time, these two terms are being misinterpreted. Stretching and range of mobility exercises are not synonymous. Stretching takes soft tissue structures beyond their available length to increase the range of movement, and range of movement exercises stays within the limits of tissue extensibility to maintain the available length of tissues. For example, a person with a periarthritis shoulder, he has most commonly the periarthritis shoulder will have a limitation of abduction rotations. So he will be restricted to this extent. For example, you can say 90 degree. So this is his range. But this is the range of movement exercise. But if you want to increase the range, you have to stretch it. So the ROM exercises and stretching exercises, the intervention, the mechanism behind it is entirely different. Before stretching the muscle, we need to know about 3 important characters of the muscle: elasticity, plasticity, and viscoelasticity. So elasticity is the ability of the soft tissue to return to its pre-stretch resting length directly after a short duration stretch force has been removed. Whereas plasticity is plastic deformation, is the tendency of soft tissue to assume a new and greater length after the stretch force has been removed. The viscoelasticity is time-dependent property of soft tissue that initiates, resists deformation, such as the length of the tissue when the stretch force is first applied. If a stretch force is sustained, viscoelasticity allows a change in length of tissue and then enables the tissue to return gradually to its pre-stretch state after the stretch force has been removed. So most of the time, especially the patients with persons with stroke or a spinal cord injury, the adequate stretching is not being followed. When we say that you have to do a stretching for 3 weeks, 4 weeks. So after 2 weeks, when they leave, then it comes to the same position. So stretching, it requires based on the extent of the spasticity. We have modified Ashworth scale of grading spasticity. So when we have 3-4 spasticity, we require resting splints and a long duration of stretching. And moreover, it is not about stretching for 1 or 2 hours a day. It requires a sustained lesser force of stretching throughout the day, which I'll be discussing. So what are the different types of contractures? You have myostatic contractures, pseudomyostatic contractures, orthogenic and periarticular contractures, fibrotic and irreversible contractures. So I would like to highlight, there are 2 stages. When a person is having a deformed stage or a deformed position of a joint, initially it may be as long as involvement of muscle alone, it is spasticity. It is relatively easy to treat by stretching, splinting, or if at all, by Botox injection, botulinum toxin injection, or a phenol block. So as long as it is within the purview of muscles, it is relatively easy to treat. But when active intervention is not contemplated at the right time, when it involves the periarticular structures and the capsule, then it becomes very difficult. So as long as it is at the level of muscle, it is relatively easy to treat. That is why whenever a person with a spasticity or early tightness or contracture, it has to be intervened as early as possible. Once the periarticular structures, joint capsules are involved, most of the time it requires a surgical intervention. So stretching exercise or therapeutic maneuver to increase the extensibility of soft tissues, thereby improving flexibility and range of mobility that have adaptively shortened have become hypomobile over a period of time. So how to stretch? So again, the question, most of my therapists, they will come, sir, how long to stretch, how to stretch? And usually in the hospitals, the patient will come, the 1 or 2 hours, they will attend the physiotherapy OPD, they will do vigorous stretching. They'll just keep pulling it. And then they will leave him in the ward for rest of the time. Stretching vigorously for 1 hour and leaving him for rest of the 23 hours doesn't make sense. So we have to stretch the muscle. We should be gentle to the muscles. We should allow time for it to stretch over a period of time so that there are certain changes that happen at the level of between the troponin, myosin and the perimysial structures so that it gives way over a period of time. So we have to be gentle. That is a lesser force applied over a period of time. Ideally, it can be achieved by resting splints. Resting splints, that is very, very essential. So just stretching aggressively for 1 hour to show all our sincerity and then leaving him for rest of the 20 to 23 hours, it is not going to help. Of course, it can cause muscle ruptures, which is again going to cause harm to the patient. A sustained or intermittent external end-range stretch force applied with overpressure and by manual contact or a mechanical device elongates a shortened muscle tendon unit and periarticular connective tissue by moving a restricted joint just past the available ROM. So we have to see what is the extent of the restriction and what are all the possible structures that is involved. If it is muscle, it is easy. Again, if it is periarticular structures, to a certain extent, we can use some adjunctives like wax heat and then stretch it. And if not, then we have to go for a surgical intervention. If the patient himself does, then it is called as an active stretching, and we assist or completely we do, it becomes an assisted active or a passive stretching. So what are the indications? When do we need to stretch a joint? When it is it has a restricted range of movements with adhesions, contractures, and scar tissue formation, and there is muscle weakness and shortening of opposing tissue have led to limited range. It is a component of total fitness or sport-specific conditioning program and may be used to prior to and after vigorous exercise to potentially reduce post-exercise muscle soreness. So these are all either there may be a limitation of movement or it can be a stretching intervention after an active, aggressive period of sports. What are the contraindications? More than the indications, we have to be very careful with the contraindications. I have seen people landing up with fractures. Especially spinal cord injured patients, they'll be on the bed for a longer time. Either they'll be on the other extreme of heterotopic ossification or on this extreme of osteoporosis. So both these can happen with different mechanism. So when they are not able to clinically diagnose this, either because of heterotopic ossification or osteoporosis, when they pull, when gives an undue pull, that it can cause fractures. So we have to be very, very careful to know about the contraindications and what not to do with stretching in what clinical scenarios. A bony block limits joint motion or reason fracture. Yes. Bony block means think of heterotopic ossification or myositis ossificans. Acute inflammatory or infectious process, sharp acute pain with joint or muscle elongation, hematoma, tissue trauma, hypermobility is already existing, then we have to avoid stretching. And sometimes what will happen, it is better to have a little tightness than having a flaccidity. You might have seen the children with cerebral palsy. The worst prognosis is with flaccid paralysis. We won't over-treat the spasticity in children with cerebral palsy because sometimes we need little tightness for the joints to be stable. So in that case, we have to really see whether the tightness has to be intervened because sometimes it may help for the stability of the patient. So we have to carefully examine and we have to assess whether it has to be stretched or not. What are the mechanical response of the contractile unit to stretch and immobilization? So both contractile and non-contractile tissues have elastic and plastic qualities. However, only non-contractile connective tissues have viscoelastic properties. The tightness or the deformity because of the involvement of muscles and the periarticular structures, the intervention what we are doing more than the contractile component, it is the non-contractile component, the perimysial tissues and also the connective tissues in between the muscles. Those are the one which really undergo certain changes which gives away the tightness, thereby mitigating the deformity. Right. So when a muscle is stretched and elongates, the stretch force is transmitted to the muscle fibers via connective tissue in and around the fibers. It is hypothesized that the molecular interactions link these non-contractile elements to the contractile unit of the muscle, the sarcomere. So the non-contractile units really play a role in undergoing the changes on your stretching efforts. So during passive stretch, both longitudinal and lateral force transduction occurs. When initial lengthening occurs in series elastic, that is connective tissue component, the tension rises, sharply. After a point, there is a mechanical disruption influenced by neural and biochemical changes of cross bridges. As the filaments slide apart, lead to abrupt lengthening of the sarcomere, sometimes referred to as sarcomere give up. So to achieve the sarcomere give up, again, you have to be very consistent with your stretching efforts over a period of time, because it involves both the contractile and the non-contractile components. And one important point is when the stretch force is released, the individual sarcomeres return to their resting length. As noted previously, the tendency of muscles to return to the resting length after short-term stretch is called as elasticity. If our stretching effort is not consistent, definitely it is going to come back to the resting position over a period of time. So what will happen if we are not stretching it and putting it into action over a period of time? Because of immobilization, it will go for muscle atrophy, weakness, demineralization of bones, osteoporosis, and over a period of time, there will be a wasting of muscles because of sarcomere absorption. And if a muscle is held in a lengthened position for an extended time period, it adapts by increasing the number of sarcomeres in series, sometimes referred to as myofibrinogenesis. So though I was not able to get more data on this, but there are a few Cochrane evidences to support this. That is, when you keep the muscle in a lengthened position, they say that there is a formation of new muscle cells. What are the determinants of stretching? So how do we stretch? Again, this is very, very important. When you want to stretch, you have to align the body parts correctly. So when you want to stretch the shoulder, so you have to make the spine erect, because even if the spine is like this in scoliosis, scoliotic posture, you cannot achieve the complete benefit of the stretching the shoulder joint. So first of all, the alignment of joints and body is very important. You have to stabilize the body, especially the joint one above and one below, if you want to stretch one joint, and the intensity should be a low intensity and long duration is ideal. So this is the example. So if you want to stretch the shoulder, this is the ideal. The person has to be standing erect. It is not stooping forward, and then the neck has to be in the right position. So when you want to achieve the complete benefit of stretching of shoulder, the positioning of the person is very important. An alignment of joints. Imagine that if you want to stretch the quadriceps, see, the person has to stand straight. It is not about the anterior pelvic tilt is there, and then even the hip joint is flexed. So when you want to stretch the muscle completely, you have to stabilize the joints, especially one joint above, one joint below in the and duration is, again, I was telling long duration, that is static, sustained and maintained and prolonged, whereas short duration stretching are cyclic, intermittent and ballistic. Let me restrict. Okay. So the static stretching, this point is important. Static stretching gives slow, short end range stretching. Again, it leads to, again, slow range stretching and fast short end stretching and fast full range stretching. So how do you evolve the stretching? First, we have to be static stretching, and then slowly you have to increase the duration and intensity of the stretching. A fine balance between collagen tissue breakdown and repair is needed to allow an increase in soft tissue lengthening. So this is all very important. So where to stretch, how long to stretch, really matters to prevent a soft tissue breakdown. So coming to ROM exercises. So we have dealt with what are the indications, contraindications for stretching, and how to stretch and how long to stretch, what are the different types of stretching. So coming to the range of movement exercises, or range of mobility exercises. So when bones move with respect to each other at the connecting points, the full motion is possible, is called the range of motion. So we have joint range and muscle range. Many times we think only about when we say range,
I'm not able to hear. Hello, I'm not able to hear. Hello. Hello, I'm not able to hear.
adapt to progressively greater demands. Since our bodies have already adapted to most everyday activities, those generally don't produce enough stress to stimulate new muscle growth. So to build new muscle, a process called hypertrophy, our cells need to be exposed to higher workloads than they are used to. In fact, if you don't continuously expose your muscles to some resistance to progressively greater demands, a process known since our bodies have already adapted to most everyday activities, exposing the muscles to a high degree of tension enough stress, especially while the muscle is new muscle growth, also called an eccentric contraction, a process generates effective conditions. Our cells need to be exposed. However, higher muscles rely on more than just activity.
Welcome back, everyone. Hope you had a great lunch. I'd like to call upon our last speaker for the day, Dr. A. Balasubramaniam, Senior Assistant Professor, Government Keelpark Medical College, Chennai. To chair the session, I'd like to invite Professor R. Rita, Department of Biochem, MGM CRI. I'd like Professor Rita to introduce our speaker before going on.
Good afternoon. Dr. A. Balasubramaniam is a Senior Assistant Professor, Government Keelpark Medical College, Chennai. Sir has done his MBBS from Government Keelpark Medical College and PG from MD Biochemistry from JIPMER, Puducherry. Also PG Diploma in Diabetology from Annamalai University, Chidambaram. He's got a teaching experience of 8 years. He's a clinical consultant clinical chemist for 7 years and has an experience in clinical trials for 5 years. His field of research is molecular genetics and computer-aided drug designing. Awards and recognitions, he's been awarded Chudiwala Endowment Gold Medal for topper in university examinations and Sri Rangam Sitaram Memorial Endowment Gold Medal for topper in MD Biochemistry. He's got around 10 publications to his account, and then also I would like to say that he's a financial advisor also. Welcome you, sir. The floor is yours.
A very good afternoon to all of you, and thank you for the opportunity to have me here with you to discuss one of very light topics. Actually, the topics have been quite heavy so far, but this is coming from a laboratory background, and you will have quite some familiarity with this topic as we go ahead and we discuss about the various biomarkers in sports and exercise biochemistry. So we'll start with some basic biochemistry about sports. Sports is nothing but it's a activity which leads to skeletal muscle contraction, which leads to energy expenditure. Basically, it's the consumption of ATPs there. And the principles of sport are three principles. Main core principles of sports are overload. Overload is a load which you can give to the muscles. And then there is specificity, which muscles you are going to train, and reversibility about the gains which have been achieved by training and the gains which are lost while during detraining. And training methods, there are three training methods: weight training, and speed training, and flexibility training. So in order to undergo all this sports related activities and exercise, the energy must come from three different sources. So this is basically depending upon the time taken by each activity, or the time which is required for each activity to be performed. For short bursts of energy, which is going to take around 7 to 12 seconds, say for example, you're running a 100-meter sprint, the basic energy is going to come from high energy compounds like phosphocreatine, high ATPs, creatine phosphate, and all those BPGs, everything. So this is a short burst of energies from high energy compounds. And for a little bit more prolonged activity, which stretches around from 1 minute to 3 minutes, the energy will come from glycogen breakdown. So whole process of glycogen is broken down into to glucose 1-phosphate, and then glucose 1-phosphate is converted to glucose 6-phosphate, which is then broken down to pyruvate via glycolysis and then to lactate. This is an anaerobic glycolysis, but anaerobic glycolysis cannot sustain for a very long time. So after a period of about 3 minutes, we have to shift towards the aerobic glycolysis, which involves generation of acetyl-CoA from pyruvate, and then this acetyl-CoA is shunted via the electron transport chain and to give rise to ATPs. So the breakdown is like this. For very short bursts, you get high energy compounds, and for a little bit sustained activity, you need the glycogen breakdown, and then finally you go for the aerobic glycolysis. So how do you improve your exercise tolerance? For the improving the high energy phosphate system, there is some kind of training called as interval training or sprint training. Interval training is you do a short burst of exercise, then you rest, cool off, then you do again a short burst of exercise, cool off, like that. But sprint training is like warm up, full exercise, then you cool off. So that is the kind of exercises you need to do to improve your high energy phosphate system, basically for the short swimmers, for the sprint runners, all those things. And how do you increase your anaerobic glycolysis capacity? This is wholly dependent upon the lactate concentration. You either find ways to decrease the amount of lactate synthesized, or you find out ways to increase the clearance of the lactate. So lactate buildup decreases the exercise capacity of the muscle. So you just have to clear up the lactate, or you have to reduce the lactate levels in the skeletal muscles. And how to improve the aerobic glycolysis is wholly dependent upon the mitochondria, because the mitochondria is the one which is hosting the electron transport chain. So increase the mitochondrial number, increase the mitochondrial capacity, increase the mitochondrial enzymes, then what you have is you have increased aerobic glycolysis, which can give rise to more amount of energy. And about the fuels, carbohydrates and fats are the most preferred fuels because the energy extraction is easier from these two fuels. Proteins are not preferred. They are not that much conducible for release of energy when compared to carbs or fats. And the muscle fibers are also divided into two types: red fibers and the white fibers. Red fibers are those fibers which are contracting slowly, so these are called as slow contracting fibers, and the white fibers are the ones which are contracting very fastly, which are called as the fast fibers. And type 1 fibers are going for aerobic glycolysis. Type 2A is the mixed glycolysis, aerobic plus anaerobic, and type 2B is the wholly anaerobic glycolysis fibers. So the muscle fibers, the color of the muscle fibers is based upon the mitochondrial numbers and the hemoglobin present in the muscle. So more the mitochondria, more the hemoglobin in the muscles, the color shifts towards the red fibers. Red fibers are the ones which give more oxidation, more electron transport chain, and more ATP when compared to white muscle fibers. And when you come to athletic performance, there is something called as aerobic power, or VO2 max. That is an amount of maximum volume of oxygen that can be consumed per kilogram of muscle. So how much oxygen can be consumed by per kilogram of muscle? And it depends on three factors. The factor number one is the amount of oxygen content in the arteries. Point number two is the cardiac output. Cardiac output is nothing but heart rate into stroke volume. And the point number three is how much oxygen can be extracted by the muscle from the arterial blood flow. So 3 points: arterial oxygen content has to be high, cardiac output has to be high, and the amount of oxygen that can be extracted has to be high. So this VO2 max, whenever it increases, the athletic performance also increases. So it's just a combination of these factors where there is multiplication of cardiac output into A minus VO2. A minus VO2 is a tissue extraction, and cardiac output is the amount of muscle, that is amount of blood that is received by the muscle. And what about detraining changes? To put in a very simpler words, suppose there is an athlete who's training for a period of time. If he stops training for 1 week, okay, so all the gains which has been achieved by this athlete, 50% of the gains will be lost by 1 week of detraining. So 50% of all the gains achieved is lost if he just stops training for 1 week. And in order to regain that 50%, he needs to train for 4 more weeks. So that is the kind of equation that is going on. So training has to be it's not like a point down process. It has to be a continuous process. It has to be monitored. It has to be propensed in a very rhythmic manner. It cannot be on and off. It's not like that. And now we'll come to the biomarkers in sports. First, what is meant by a biomarker? A biomarker is an indicator of a normal metabolic process. It can be a metabolic process, can be any other process, but this biomarker is an indicator of a normal process. It is supposed to change when the process becomes abnormal or whenever there is an intervention. So the intervention can be a pharmacological intervention, it can be a physiological intervention, it can be anything. So this biomarker as such indicates a normal process which will change when there is a abnormality in the normal process. And what is blood screening, blood monitoring, and blood profiling? Blood screening means it's just a one-time process. So you are screening something or someone, and then over a period of months, you are not touching them for 6 months or 1 year. But blood monitoring means high frequency measurements for every week, for every month, or like a period of 2 weeks once, or period of 3 months once. So it's a continuous process. And blood profiling means compiling all the data of your blood monitoring. So these are the differences. When it comes to athletes, it has to be blood monitoring followed by blood profiling. So it is not a screening, is not an effective tool. It has to be blood monitoring and blood profiling. But while you are doing blood profiling, there are 4 important considerations. What are the 4 important considerations? Your normal biological reference intervals for the population is not applicable to the athletes. So that is the point number 1. Athletes have their separate biological reference intervals. I'll come to that. And then there are pre-analytical considerations. How there are 10 factors which can affect the variables when it comes to athletes, and the interpretation is also unique. Like it's not like you get a report from lab and you are interpreting. It's not like that. The athletic profile has to be interpreted with some amount of expertise. And there is another consideration, which is plasma volume shifts. Plasma volume shifts means athletes frequently go into hypovolemia or hypervolemia because of the dehydration or because of the increased fluid consumption. So this also has to be kept in mind while you are interpreting the athletic values. In order to achieve all this, nowadays there is something called as a sports team. This sports team includes a person called as a sports scientist. So sports scientist is the one who analyzes the data, who maintains the data of each team member, and also gives him or her suggestions on how her biomarkers get varied. Next, we'll come to biomarker suitability. In biomarker suitability, we need to have a certain checklist to identify whether a biomarker can be applied regularly or not. Number 1, evidence, past evidence must be there that this biomarker is a valid biomarker. So you cannot just go around and test something on your own and put it on an athlete's checklist. Number 2, application. What is the biomarker exactly giving the data to you? Which data it's going to give it to you about the athlete? The third one is the validity, whether how much time this biomarker values will stand, whether it can stand for 2 weeks or it's for 6 months or it's for 3 months, whatever it is. And this biomarker must also take into consideration the variability. Variability means analytical and biological variability. That is, in the lab, what all variations can come. Within the person, what all variables can come. And it must be easy to collect. It must be easy to analyze. You should not be selecting a biomarker which requires shipping the biomarker to somewhere like US or UK and then get it analyzed. No, it is not like that. When you transport, when you ship something, the point of variability will increase. Okay. And diurnal variation. Diurnal variation is between day and night, the variation should be minimal. It should not vary between so much between the day and night. And cost of the biomarker. Cost also, it should be affordable. Athletes receive funding. You cannot go ahead and push some very costly biomarkers to athletes. And the covariates is other factors which can affect the biomarkers. So like travel, jet lag, exercise, activities, that also has to be taken into consideration. Okay, can I get some water? I'm sorry. And let's come to points of testing, where you get tested. What are the points in which you get tested? Okay, so basically an athlete's life is like this. You have a pre-season, you have a competitive season, followed by an off-season. So these are the three phases the athletes go through. So before the competitive season, they have something called as a pre-season. You will test the athlete at the end of the pre-season. That is point number one. And during the competitive season, you will test the athlete whenever there is increased activity, or before an event or after an event, or whenever he or she has an injury. That is the time you will test the athlete. And once the competitive season is over, when he or she enters the off season, you will test the athlete. This will be taken for establishing the baseline values. So that is the baseline value for the athlete. So pre-season, competitive season, off season. All these three things has to be taken into account. But while you are testing for biomarkers in athletes, there are something like single biomarkers versus multiple biomarkers. Any point of time, a single biomarker will not give you proper data. It has to be multiple biomarkers which are put together to be considered to give a holistic picture of the athlete's performance. And when you select the biomarkers, always there is sensitivity issues and specificity issues. Almost minimum 90% sensitivity must be there so that the biomarkers are considered to be valid. And the gray area is, as I told you, the reference ranges. The reference ranges which you get in your kit inserts, which you get in your population-based reference intervals, they are not applicable. There is a lot of variation in athletes compared to the normal population. And there is a lot of variation between the athletes also. Like you cannot compare the ranges in boxers versus the swimmers. You cannot compare the swimmers versus the rowing people. Thank you. Yeah, just a minute, sorry. And the last point is all the biomarkers are contextualized. Okay, contextualized means based on the context, based on the situation, you need to interpret the biomarkers. So these are limitations of athletes testing. And to be really shocked, there is one thing: athletes are actually very hesitant about giving blood. Okay, because there is a paper which says if you withdraw 180 ml of blood from an athlete, then the performance suffers. So that is the kind of data. So like a blood transfusion is hated by the athletes. They're not going to give you that much blood. And that blood also, whenever they are giving, it has to be for every drop of athlete's blood, more questions has to be answered. That is basically the crux here. Okay, so you need to be very specific. You need to know what is going to cost, what is going to be the turnaround time, at what point of time you are going to give the results, within 1 day, within 2 days, within 3 hours, how much is the test, and the timing, whether you will take in the morning or you're going to take in the night or you're going to take in the evening, whatever it is. And there is something called as circulating hemoglobin, total hemoglobin mass. That is one of the very good indicators, but it is not measured like worldwide. Okay, it's that is that circulating hemoglobin can also affect the test results. And another one limitation is immune cell populations will also affect the results, but then the quantifying the immune cell populations is going to be a problem. Say like a cluster of differentiations, or whether monocytes, macrophages, quantifying them is going to be very problematic. And then the intracellular markers, which are not present in the circulation. So you are not going to take a biopsy and test them. So it is very difficult. When you come to athletes, whatever is present in the blood, that can be tested, but you are going to take a biopsy, muscle biopsy, and you testing them is going to be difficult in athletes. That is all going to be athlete. In fact, invasive testing itself is very difficult in athletes. So we are evolving with new technologies. These are like butterfly microfilament needles, paper bloods, so that much blood is not drawn or much blood is not used. Just take a drop and blot it. That is a kind of advancements which we are going through. So this is a whole picture about the pre-analytical considerations when it comes to taking athlete's blood. Point number one, I will go one by one. When you are applying the tourniquet, be very careful. Do not apply the tourniquet for a lot of time. It's going to affect the blood gases, electrolytes, and iron parameters. And then centrifuge. Okay, when you are centrifuging, proper centrifuging, at proper RPM and proper procedures has to be followed. Otherwise, then potassium bicarbonate hemolysis can happen. Then potassium bicarbs can get deranged. Order of draw must be followed. Which color tube is going to be going first, and then followed by which color tubes. All that has to be maintained, and that's to avoid the contamination. And when you are taking the blood, you must be very sure whether the athlete has undergone exercise and giving blood, or whether he is in a resting period, or whether he is in an off-season period or a pre-season period. Because any intense activity is going to change some of the parameters. So that has to be taken into account. Basically, we advise no strenuous activity, no high-intensity activities before taking blood for at least 1 or 2 days before taking the blood. And also I consider his hydration status. So hydration, when there is dehydration, the parameters are going to give higher values. That is because of the hypovolemia. Dilutional, when there is a more hydration, then it is going to give dilutional bias. So that is also to be taken into consideration, especially when you're measuring electrolytes and hematocrit. Okay. And when it comes to women athletes, menstruation, menstrual cycles, hormonal contraceptive pills, all the history has to be taken, because that are going to affect parameters like LH, FSH, and sex steroids, all those things. And glucose can be affected whether the fasting, but preferably we are taking the blood in the fasting status. Okay. And stress can affect cortisol and endocrine hormones also. The athletes are always under stress, so that also can have an impact. And lastly, the time of the day. So diurnal variations, jet lags, all those things can affect the melatonin, cortisol, and other hormones. So all the 10 considerations should be considered. And sometimes we ask, people ask us, volume shifts are the most typical problem. How much is the water that has to be consumed by the athletes? A basic idea I can tell you is, for every kg body mass, 7 ml can be consumed. That is the amount of water that can be consumed. Okay, so suppose it is 60 kg, then 60 into 7, that will be 420 ml. So that is the amount of water that must be consumed from the time of waking up from the bed to the time that which blood is drawn. So within that period, that much blood has to be consumed. Okay. So we will come to the statistical considerations of biomarkers. Once you have taken the blood, once you have established your biomarkers, what you need to do is you need to establish the athlete-specific biological reference intervals. Now, when you are taking athlete-specific biological reference intervals, you must first establish a baseline during the off-season period. So you will compare the athlete's values only with his or her baseline. So you cannot go ahead comparing that with the normal population's levels. Number 2, this baseline value and comparison is also an adaptive reference range. During the competition, his values are going to get changed. During an injury, his values are going to get changed. So everywhere the adaptive reference range must come. So when we come back to this, there is a 2 parameters, 2 terminologies which you should be able to understand very clearly. There is something called as CDT, critical difference threshold. Critical difference threshold means quantify the variation which can happen because of any factor and incorporate it into the interpretation. So there is some factor which is happening that is going to affect the values, just incorporate into the interpretation. That is called as a critical difference threshold. And then there is something called as index of individuality. Index of individuality means within subject variation divided by between subject variation. That is called as index of individuality. So index of individuality is nothing but how much variation is existing within the same person divided by how much is existing between 2 athletes. that is called as index of individuality. These are the factors which must be statistically deployed when we come to interpretation of athletes' blood reports. I can show you the pictures here. Now you see, okay, see here, this is the graph of a normal population's biomarker reference levels. Okay, now if you extrapolate an athlete's biomarker reference level, the blue color thing, blue color upper portion is called as the critical difference threshold. So now you can see that athletes have an extra level of range of zone where the blood markers are moving into. So that is the difference between the normal people and athletes. You should not interpret that as high values. It is actually the normal values for them. Okay. And when you come to the second picture, the blue color line, see the blue color line. And the data points are collected, normal people and between the athletes. And during the athletes also, so the bars represent the normal people, the blue color points represents the athletes, and the red color points represent the athletes with infections, with bone mineral density, bone stress responses. So in the same athlete itself, there is a variation between normal during the season and when there is an infection, during the season and when there is a bone stress response. So all these things must be taken into account. So what you want to know is, do not interpret the values as normal and athletic. Athletic range is totally different. Establish the separate biological intervals, establish the separate concentrations between the athletes and also within the same athlete in his baseline period as well as the exercise period. Now we will come to the biomarker categories. So what are the 7 different categories of 8 different categories of biomarkers is biomarkers of nutrition, biomarkers of hydration, muscle status biomarkers, cardiovascular biomarkers, injury status biomarkers, inflammation biomarkers, oxidative stress biomarkers, and allergy biomarkers. We will take one by one, and I am going to give you the insights into them. I am not going to push numbers here. Biochemistry is a field which is dreaded because you will have to remember 15 to 50, whether it's micrograms or milligrams or deciliters or liters. I will refrain from using the numbers. The numbers are always available for you on the web. So what I'm going to do is I'm just going to tell you the markers and some salient features here. The whole point here is you have to know what are markers that are available. So, okay. And I am not going into the details about the doping biomarkers. That is a whole field in which we can speak for one single whole day. So I'm not touching the World Anti-Doping Agency or doping biopanels or athletes' biological passport. Maybe I will give you some details towards the end of the presentation. But right now, the markers as such, we will start with nutritional biomarkers. So in nutritional biomarkers, we have a panel of nutritional biomarkers. We will take one by one. The first marker is going to be red blood cell fatty acids. So you all know that whenever there is a reduced glucose or glycogen availability, there's going to be fatigue. So there is another group of markers which are called as RBC fatty acids markers. These are the markers which will show you the fat intake, dietary fat intake. In that also, the most important biomarkers are belonging to a family called as omega-3 fatty acids. Okay, so omega-3 fatty acids, the most commonly known omega-3 fatty acids are alpha-linolenic acid, eicosapentaenoic acid, and docosahexaenoic acid. So EPA and DHA are the most common omega-3 fatty acids, and omega-3 fatty acids are the ones which will decrease the inflammation, and there is something called as perception of pain. So the athletes will perceive pain lesser when there is more omega-3 fatty acids, which means that their performance will be improved. So red blood cell fatty acids, especially omega-3 fatty acids, improve athletes' performance. So they're measured as such. Okay, so normally we suggest 3 grams per day intake for recommended dietary allowance or dietary value for the people. Means for athletes it will be 6 to 8 grams per day. They need to take a lot of omega-3 fatty acids. Okay, and as I already told you, carbs and fats are preferred, but proteins are not preferred. But proteins, in the proteins, when the proteins levels is low, it is going to lead to some amount of problems, especially hypoalbuminemia. So albumin is a marker because whenever there is decreased albumin levels, the performance and the recovery of athletes from injury is also reduced. So low albumin means bad. It's bad for the athletes. And also albumin has a relationship to IGF-1, okay, insulin-like growth factor 1. And IGF-1 is a performance increasing biomarker. So low albumin means decreased performance, decreased recovery, and low albumin also means that decreased IGF-1. So low albumin is a totally bad scenario for athletes. And most commonly, low protein, low albumin, I have told you that. Among the amino acids, which is the amino acids? I'm speaking about protein biomarkers. So among the amino acids, which is the most important group of amino acids means the branched chain amino acids, valine, leucine, and isoleucine. If you're able to quantify them, they are going to be the muscle status indicator proteins. So branched chain amino acids are the number one amino acids which are preferred. And also there is a amino acid called as taurine. Taurine is a byproduct of cysteine catabolism. Taurine as such is more. Whenever taurine is more, it just means that there is some amount of muscle damage or injury or impaired functioning of muscles. So taurine is one of the important amino acids. And taurine is also used for conjugation of bile acids. You all would have known primary bile acids, secondary bile acids, glycolic acid, taurocholic acid. That is the taurine which we are speaking about. And tryptophan and glutamine are other important amino acids. More tryptophan and decreased glutamine means fatigue and suboptimal training capacity. So whenever there is decreased amount of glutamine, it means that the athlete is facing more fatigue. So he or she cannot perform well because the fatigue is catching up early with them. So branched chain amino acids, taurine and glutamine are the three important amino acids which are noteworthy. About the micronutrients, vitamins and minerals. Vitamin D, as you all know, is very much important for increasing the performance. The normal range of vitamin D is 30 to 100. We all know that, but most of us will have less than 10. That is also known because we are not exposed to sunlight. We are always sitting in the AC room. For athletes, the target is to maintain vitamin D greater than 50 nanograms per ml. So that is the amount of target which the athletes are supposed to maintain. And vitamins A and D are also known as antioxidants. So oxidative stress to be curbed. And low calcium, low iron, and low vitamins, all of them leads to increased stress fractures in athletes. So all these nutrients has to be replenished. Along with that, magnesium deficiency can also cause muscle weakness and spasms, and zinc and chromium deficiency occurs in athletes who are marathon runners, athletes who are triathlon runners. So endurance means you're doing a lot of activities for very long time, like running a marathon, like jumping for a long time. That is kind of athletes. So in all these places, magnesium, zinc, and chromium to be noted. With that, nutritional biomarkers are over. We are coming to hydration biomarkers. Dehydration is one of the predominant problem in athletes. There is something called as 1-2-5-7 rule. So see, if you are looking into this 1-2-5 is a very interesting set of numbers. This is even employed in your currency. Any country comes to currencies, you will have 10 rupees, 20 rupees, and 50 rupees, 100, 200, and 500. So that is the amount of currency which is to be used when there is a barter exchange system. That will be the amount of easiness will be more. Same rule applies to dehydration also. 1% dehydration, 2% dehydration, 5% dehydration, and 7% dehydration. So 1% dehydration means basically you will feel thirsty. 2% means you will have some jittery symptoms. Okay, you will feel irritable. 3% means fatigue, loss of appetite, all those things. 7% is 5% is fatigue, irritation, loss of appetite, decreased cardiovascular output, all those things. 7% is very severe, you will have to be admitted. So that is the amount of dehydration. For athletes, even 2% dehydration will reduce their performance. So dehydration is to be considered very, very precisely. And whenever there is dehydration, there is an acute decrease in body weight. So that is one of the indicators. Like for every 1 ml dehydration, 1 gram body weight will change. That is the amount of change which can be expected. And this is an involuntary dehydration. Involuntary dehydration means sweat, loss via urine, all those things which you are not routinely expecting, that you are getting dehydrated. Sitting in an AC room, you are getting dehydrated, involuntary dehydration. To measure dehydration, we have certain markers. Now, one of the most important gold standard marker is serum osmolarity. Okay, serum osmolarity normal range is 280 to 290, but then in athletes, when the osmolarity is greater than 295, it means that he or she is dehydrated, and sodium levels greater than 145 means they are dehydrated. So these are markers of dehydration. And also blood urea nitrogen to creatinine ratio 20, greater than 20, also means it's a significant dehydration. So osmolarity and sodium levels and bun creatinine ratio greater than 20 means dehydration. Anyone can tell me what is AVP? Arginine vasopressin, otherwise called as antidiuretic hormone. So antidiuretic hormone is a marker for dehydration, but it's quite expensive biomarker, quantifying antidiuretic hormone. There is a cleavage product from antidiuretic hormone. That product is called as copeptin. Copeptin is also a marker for dehydration, and urine specific gravity more, urine osmolarity more, all those things are markers of dehydration. In fact, there is some doctor called as Dr. Lawrence Armstrong. He devised a color scale for athletes. You put a drop of urine on that color scale. It ranges from 1 to 8. If you are having more than 5 range means more high colored urine, then you are classified as a dehydrated athlete. So that is a marker which is used for athletes. Okay. Many people ask us whether thirst can be used as a marker. Thirst can be used, but then 1% only will lead to thirst. And then there is another problem with thirst. You will perceive thirst as differently. I will perceive thirst as differently. It is not constant. Sometimes you can perceive thirst and live without drinking water, but athletes can sustain thirst for a long time. So it's not a standardized marker. We cannot do that. Same goes for saliva rate. So some people say that when there's a dehydration, saliva is like it's affected, or sweat osmolarity, or tears osmolarity. All those things are very insignificant markers which are not standardized, so we cannot use them. Now we'll come to the muscle biomarkers. In muscle biomarkers, very crudely, not very crudely, very advanced biometronics markers. They can take the skeletal muscle quality, the size, the structure, the composition of the skeletal muscles and analyze it, because this all requires very high-end facilities. But at a blood level, predominantly we test the endocrine markers. Among the endocrine markers, testosterone and cortisol are the most important markers. Testosterone is a marker of training, how much training you have undergone. And cortisol is antagonist to testosterone. So testosterone is an anabolic marker. Cortisol is a catabolic marker. So as I already told you, any individual single marker is less beneficial when compared to the combination of biomarkers. So we always consider testosterone to cortisol ratio. So testosterone cortisol ratio is a better biomarker than individual testosterone or individual cortisol. And this is very sensitive because whenever there is an injury, whenever there is a overload, overtraining, testosterone cortisol ratio falls by 30%. Testosterone cortisol ratio falls by 30%. So this is the whole panel of biomarkers when it comes to muscle biomarkers. So you can see here, testosterone is a synthesis biomarker, cortisol is a catabolic biomarker. So testosterone cortisol ratio is a marker for anabolic catabolic balance. And DHEA is a sex hormone, which is also a precursor hormone for testosterone, and growth hormones, insulin-like growth factor, all these things are markers which are increasing the performance. If you take into the data of doping, so doping which is used by the athletes, the most commonly used doping is, previously it was sex steroids, okay, anabolic hormones, this testosterone, testosterone, and all those things. But of late, the most commonly used or abused is erythropoietin. So erythropoietin is the erythropoietin and erythropoietin receptor activators are used because the oxygen extraction, I told you, to improve the performance, the VO2 can be increased because of this. So erythropoietin injections and erythropoietin receptor activators along with anabolic steroids, these are the things that WADA is World Anti-Doping Agency looks for in an athlete. Okay, and sex hormone binding globulin is another important marker because sex hormone binding globulin is the protein which carries the sex hormones, so which carries the steroids. So there is always a problem of overtraining in athletes. Whenever there is a athlete who is pushing too hard beyond the limits, what happens? What is the markers to identify whether an athlete has trained so much or not? The number one marker is lactate. As I told you, whenever there is overtraining, there is lactate building up in the muscles. And this lactate, when it reaches greater than 4 millimoles per liter, it means that the athlete has overtrained. So lactate buildup in muscles is overtraining. And also creatinine greater than 1.4 suggests overtraining. And creatinine kinase greater than 300 also is overtraining. So lactate, creatinine kinase, all these are markers for overtraining and muscle injury also. Ammonia is also there. It's also a marker for intensity of exercise. So if you have a holistic picture, all that you need to worry about endocrine markers is if I will be happy if you can take this home: testosterone, cortisol, and the markers of overtraining. Okay, so these are the markers which you need to look for when it comes to training, endocrine responses, and overtraining in athletes. Then we are going to the markers of cardiovascular performance. In cardiovascular performance, the most common problem in athletes is iron deficiency, and that too especially in endurance athletes. When there is iron deficiency, all these things can happen. There is reduced performance, there is reduced VO2 max, there is reduced energy availability, there is reduced training volume, more fatigue, more lactate. So the performance greatly suffers when there is decreased iron. That is the problem with decreased iron. And what is the markers of iron profile? Ferritin is one of the very common markers which is used, but then remember that ferritin has a lot of variation. So more reliable markers to iron status can be used. These more stable markers, reliable markers are total iron binding capacity, transferrin saturation, and soluble transferrin receptor levels. All these things can hopefully give you an insight about cardiovascular performance. If you want to put it in a nutshell, there are 3 parameters and 3 levels which I am going to give to you. Hemoglobin level less than 11.5, ferritin less than 12, and transferrin saturation less than 16 means that athlete is going to perform poorly. This is the levels you need to know. Hemoglobin less than 11.5, ferritin less than 12, transferrin saturation less than 16. And what I have mentioned in red, iron deficiency without anemia is more common in athletes than iron deficiency anemia. So athletes present without anemia but with iron deficiency. Not always iron deficiency leads to anemia. Okay, in normal population, iron deficiency leads to anemia, but in athletes, iron deficiency can present without anemia or without decreased red blood cell populations. Homocysteine is another crucial marker which has to be measured because athletes are always running at a risk for cardiovascular attacks or cardiovascular diseases. So what happens is a thiol group, homocysteine is a sulfur containing derived amino acid. The thiol group is there. It is increasingly oxidized, which leads to reactive oxygen species and which curbs the endothelial function. Endothelial dysfunction occurs. So all these things is going to affect the cardiovascular performance, cardiovascular disease. When homocysteine levels is greater than 1.9 micromoles, there is a 16% increased chances of that athlete getting a cardiac attack. So the homocysteine levels also need to be measured on a consistent basis in athletes. Sometimes cardiac troponins are also preferred, and they can be, in the absence of symptoms, they can suggest cardiac muscle injury. So cardiac troponins, homocysteine are other biomarkers of CVS system. And let's come to the injury biomarkers. three main categories of injury biomarkers. The number one, I will go with boxers, those who are doing boxing. The most common injury suffered by boxers is concussion injuries. You get the punches landed onto the head and your brain goes for a toss. So that is called as a concussion. Okay. So the concussion injuries are relatively very common in boxers, but they are very difficult to assess, because directly if you measure the brain injury biomarkers, that tau protein biomarkers or the neurofilament biomarkers, it's very difficult, very expensive, not available in all the countries. It's going to be total chaos. But then there are certain markers which can be widely standardized when it comes to concussion injuries. These markers are neuron-specific enolase and S100B protein. So these are the two markers which can be used in boxers. The second injuries, which is most common, especially in women, is stress fractures. Okay. When it comes to female athletes, there is a problem called as the female athlete triad. Okay. There are three conditions which are leading to this female athlete triad. What are the three conditions? Low energy availability. Second, the hypothalamus pituitary gonadal axis will get affected by this low energy availability. So there is amenorrhea or menstrual dysfunction, and followed by low bone mineral density. So all these three factors put together increases the chances of osteoporosis and increases the chances of stress fractures in women, especially female athletes, female athlete triad. Low energy availability and amenorrhea or menstrual dysfunction, low bone mineral density, all those things leading to stress fractures. The third common causes of injuries are ligamental injuries, that too especially anterior cruciate ligament injuries when it comes to footballers, mostly footballers. But unfortunately, there is no biomarker which can predict in advance whether you will get a ligamental injury or not. So we cannot predict that. But after injury also, it is suggested that you are going to get operated for that ligament. Ligament reconstruction is done. But then the response, we don't know how you will respond, how your body will respond. So we cannot quantify that response. They are suggesting that in the early post-operative period, you can go ahead for markers like collagen type 1 and 2 cleavage products. We can do this in Roche platforms also, Roche Cobas platforms. We have these markers, collagenases, collagen N-type fragments, all those things, N-peptides, T-peptides, all those things. So this can give an idea whether the athlete will recover partially or whether the athlete will recover fully if you are undergoing ligamental reconstruction procedures. And then we come to markers of inflammation. On markers of inflammation, the most common marker which can be used is CBC. Okay, CBC. See what happens, you need to understand the workflow. When you are subjecting a muscle to chronic exercise, the inflammation kicks in. So there is a lot of chronic inflammation which is happening in the muscle. And this can lead to recruitment of monocytes, lymphocytes, and then macrophages. Release of a lot of cytokines and pro-inflammatory molecules starts to kick in. So all this will increase the shift of the population from the neutrophils. Neutrophils will increase in number. Okay, monocytes can increase in number. Macrophages can increase in number. All those things can happen. So the immune system activates, it goes to the liver, and liver starts to secrete the acute phase proteins. So all these things are going to be happening in the blood, and these are going to cause the lesion in the muscle, and then the muscle injury will release the markers like I told you, creatinine kinase, myoglobin, troponins, all these things will be released from the muscle. So this is the picture. More exercise, more inflammation leading to release of acute phase proteins, and then damage to the muscle releasing the injury biomarkers, all these things. So CBC is the most common test, and if you are good enough, your eyes can pick up good enough, you will notice the shift in the population of cells. There is also an additional advantage whether the athlete is suffering from infection or disease, that can also be found out in by taking a CBC report. And if you are wanting to, as I told you already, it is very difficult to quantify the immune cell populations. But if you are still wanting to track the recruitment of monocytes or immune cells during inflammation, you can go ahead with two markers. The first marker is called as the MCP1, monocyte chemoattractant protein 1, and soluble intercellular adhesion molecule 1, CAM1. That is called as a second marker. So both these markers can give a picture about how much monocytes or macrophages has been recruited to the injury or inflammatory site. And you can also go for cluster of differentiation markers like CD40, CD154, all those things to measure the activity of immune cells. And about acute phase proteins, I'm not going to go into much details. CRP is one of the common markers which is used for acute phase proteins, along with P-selectin and E-selectin and von Willebrand factor. The whole human system is based on the oxidative stress. Oxidative stress is a very simple topic. There is a balance which is existing between oxidants and antioxidants. Oxidants are free radicals, or supposedly causing free radical mediated injury, and antioxidants are supposed to fight against them. So what happens when the free radicals attack the fats? When the free radicals attack the fats, they get converted to malondialdehyde. So MDA is a lipid oxidation marker. When the free radicals attack the proteins, they get converted into protein carbonyls. So protein oxidation markers are called as PCs. Okay. So the antioxidant enzymes which fight against these things, catalase, peroxidase, glutathione peroxidase, superoxide dismutase, all those things are antioxidant enzymes. Basically, those athletes who are undergoing resistance training, they are supposed to have more free radical generations, increased reactive oxygen species. So all these things, they were thinking that increased reactive oxygen species means these athletes will suffer. These athletes will have more free radical mediated injury. But actually, it is a paradoxically advantageous position, because when there is more free radical production, it also kickstarts more antioxidant production. So that can also work like two sides of the blade or two sides of the coin. Increased free radicals can also lead to increased antioxidant synthesis. And then we came to biomarkers of allergy. There are many allergic biomarkers, but I will stick to only one, IgE or immunoglobulin E. The problem with athletes is athletes take curated diets. Curated diets means certain specific diets are being given to, especially fishes, shellfishes, all those things. So when the athletes are taking diets like this, nuts, fruits, some people can get allergic to some of the substances. And this allergy is significant when the immunoglobulin levels is greater than 0.35 kilounits per liter. So that is a kind of allergic response which we can expect when there is allergy. When there is IgE response, we can expect when there is an allergy. But the problem is, allergy, first of all, reduces the performance of the athletes. The number two is, you can't just give any kind of medications to athletes as you wish. There is a lot of anti-doping guidelines. There is a lot of WADA guidelines in order to administer any kind of pharmacological intervention to athletes facing allergy. So you need to be very careful. You need to quantify specifically, tell them what is the allergic source, cut the allergic source, intervene, take the permissions, and follow the proper guidelines. Okay. So as I was already told you, I'm not entering into WADA guidelines, but then there is a program called as ABP program. ABP means Athlete Biological Passport. It is called as an Athlete Biological Passport. Athlete Biological Passport is a scheme which was introduced in the 2008, 2009, all those periods. The World Anti-Doping Agency, what it does is, it maintains an electronic record of every single individual athlete, of all the biomarkers being tested on that athlete at varying points of time. So this is called as a longitudinal data. So this longitudinal data, if you see a athlete's biological passport, it will tell you information of all the testing that has been so far done on the athlete in his career. And based on the athlete biological passport, many athletes have been disqualified. Many athletes have been found guilty of using drugs. The first one is very notorious. He was a athlete who goes by the name Helder Ornelas. Okay, so he was the first one to be disqualified by using athlete biological passport. And most commonly the cyclist. Okay, cyclist, or 26 cyclists have been banned of this 20 of them has been found using the erythropoietin abuse. Okay, so that is about the athlete biological passport. So coming to the summary, I talked to you about the basic biochemistry behind exercise and sports. I talked to you about, I told you about the biomarkers. What are the biomarkers? When to test the biomarkers? Which biomarkers to select? And when to, how to test them. And I also spoke to you about the pre-analytical consideration and statistical considerations prepared specifically towards athletes. And about the limitations of biomarkers, what are the conditions in which we have to take into account while we are testing athletes, and about the various biomarker categories and their applications also. So these are my references, and not much data can be incorporated within a small period of time, but whatever questions or doubts you have, do please let me know. I will answer them at my level best. And thank you so much for the opportunity, and I wish you all the very best. Thank you.
Thank you, sir. That was a very succinct explanation from the basics to the advanced biomarkers of exercise. If there are any questions from the audience.
Good afternoon, sir.
Yes, ma'am.
Myself, Malini from DMC. Could you please explain about the red color line, iron deficiency, anemia?
No, what happens is iron deficiency as such happens means what is going to be, what is anemia? Anemia is actually we are having a decreased red blood cell population and decreased capacity, decreased fatigue, all those things. So a particular level of iron deficiency will lead to anemia when it comes to normal population. But in athletes, even if your red blood cell population is going to be normal, this decreased iron will reduce their performance. So this is what I meant by iron deficiency without anemia. So iron deficiency with decreased RBC counts is for us. Iron deficiency with normal RBC counts is also detrimental to the athletes. So that is exactly what I meant. That is the reason why I put you that a particular slide where the iron deficiency is going to lead to a lot of effects. Decreased Vmax, increased lactate formation, decreased endurance, all those things will happening. So irrespective of whether you are having an anemia or not, if the iron levels are low, the athletes are going to perform badly. And when I'm telling badly, do not think badly. It's not that bad. Every second is bad for them. Okay, every microsecond is bad for them. So there is a minor difference between 8.2 seconds and 8.4 seconds, but then the athlete loses. So once he's lost, he's lost. Okay, nobody remembers the losers, right? Only the winners are remembered. That's it. Thank you.
You were telling markers, testosterone, cortisol level, 30 something like
Yes,
that,
ma'am.
used as markers for athletes. Is it the same value for male, females, or there is a difference?
No, ma'am. Everywhere, see, actually, when it comes to athletes, you cannot go for males, females even. It is even between the males, even between the females, it differs actually. It's a generalized value. Okay. In females, the performance is the testosterone cortisol ratio is bound to be even more actually, because this testosterone is going to get converted to estrogen. Okay, so there's a lot of factors in play here. We are just standardizing this for athletes as such, but I would recommend do not consider male, female, person A or person B. It is person A, his baseline, his activity during exercise, his activity during off season. That is exactly how the reference levels has to be maintained.
It was a wonderful talk.
Thank you.
Eye-opening. Thank you, sir.
Do we have any online queries? Thank you, sir. Now I request Professor Sumadhi ma'am, HOD Biochemistry MGM CRI, to present the memento to Dr. A. Balasubramaniam. Now we like Professor Sumadhi ma'am to hand over the memento to our chairperson, Professor Rita ma'am. Sorry, sir. With the end of our last scientific session, I hope all of you had a very intriguing and enlightening time as you were here. Thank you all of you for actively participating. I thank all the speakers, chairpersons, and dignitaries who are here to share the knowledge with us. I kindly request everyone present here to join us for evening tea, and we'll have the validity function after that, which will begin. The validity function, which will follow right after. Right after now.
Yeah, thank you all. It has been wonderful for the past 2 days. We have a very good number of participants who have been sticking with us for almost 2 full days. And we have offline participants, online participants. I should really thank each and every one of you for having come here. I know that a few of you are here for 3 days now, with including the workshop. And I am very sure that you would have learned at least 10 points, which is totally new from what you have learned all these years. Can I take it as an yes? Yes. So that serves the function. And as I promised earlier in the validatory function, that we are sure, and we were very sure, that at the end of this conference, you will be knowing about the epidemiological or genetical, anatomical, biochemical, as well as physiological and therapeutic effect of exercise. I hope we kept up our promises. To the end of the session, I would like to have feedback from 2 peoples, one online and one from offline. If anybody is willing to give the feedback, share the feedback, we will be able to take. Yeah, we'll have it from online first, followed by offline. You can have your comments, you can pass your comments about this 2 days session. Anyone is willing, you can raise your hands in online. We will unmute you for a short time. Yeah, we have one participant who has raised the hand, please. Professor Parthare. Yeah, we have Srimati also.
Another one, Dr. Smriti also.
Dr. Smriti has also raised her hand. After you, sir. Yeah. Yeah.
Thank you. Yeah, I'm Partho Rai. I'm from Kolkata, and I have really enjoyed coming to this meeting. I am a neurologist, and I have a neuromuscular special interest as part of clinical neurophysiology. So this conference with anatomy, physiology, and biochemistry was a good revision for me to go back about 30 years approximately in time to revise all the muscle histology, anatomy, embryology, and the physiology and the biochemistry. So that was one. Secondly, as a clinician and going into preventative neurology, I can see the impact of obesity and diabetes in India. And therefore the solutions will include exercise, and the problems of sarcopenia, which is true with muscle, and the metabolic disturbances that we covered so very well, is very important. I learned a lot of new things, including fascial planes, which I had not learned when I was a undergraduate student, and the advances in the fascial architecture, and then again all the complexities of the organization and the connections of the musculoskeletal system. So this was basically new learning. I have certainly learned more than 10 things in the last 2 days, and I've asked a lot of questions, including on basic science. So I'll keep it short. I've learned quite a lot, and I hope that we can translate all the research information into the bedside for patients, and likewise take the problems of society in India, health-related problems, back to the musculoskeletal system and gain from it well-being. We will learn to promote, and more importantly, we doctors need to get our own health better so that we can live longer and have better quality of life for our own enjoyment and to successfully look after society. Thank you and Jai Hind.
Thank you, Jai Hind, sir. We will hear it from the offline speaker, and then we'll again come to the online speaker, online participants.
So myself, Dr. Sarah from AIMS Mangalagiri. So I feel it's worth all the way traveling from AIMS Mangalagiri to attend this academic feast. Really, all the topics were very nice and it was eye-opening. Many topics which we don't know, we had considered that this is not of importance, gained its importance attending here. Initially, I thought conference means in other conferences to fill up the spaces, there will be some talks. It was every talk, the topic was unique and it was apt for the conference also. Thanks to the organizing committee, Dr. Janit Berlin Raj, Dr. Sumati ma'am and Dr. Chandra Philip ma'am and my friend Dr. Anita Nancy. It was a wonderful experience. Thank you.
Thank you, Dr. Sarah. We will give it to Dr. Smriti. Yeah, please.
Hello, good evening, sir, and good evening all of those who are online and offline. So it was a really very informative, very interesting session. So I would like you, if you to revisit this conference once again, if you just load it on YouTube or anywhere. I would like to revisit this session, and definitely I would like my kids and my students to listen to all the sessions what were there. Really very interesting. I was very much impressed, and I think it was the best thing that we could do it attend it online also. So this was the best part, and everyone was papers or posters online. Offline, the people could present the paper to attend this conference online and even present our papers. Thank you so much, sir. I would definitely like you to upload these videos, these sessions, so that just to remind ourselves about exercise, about all those things, and it is a great motivation also for us. I think most of us might have been motivated to do exercise or to continue these exercises. Thank you so much, sir.
Thank you, madam. Point well taken. All the sessions were live in YouTube. We will post the link to the WhatsApp group. We will also send it through mail. Thank you.
Definitely, sir. Thank you, sir.
Thank you. Yeah.
Thank you, sir.
Now we will hear it from Dr. Aisha. Dr. Aisha, over to you.
Yes, sir. Good evening, sir. Respected organizers, like I'm from AIMS Devghar. I was attending this conference online, so I never felt for a moment that I'm not there, because everything was so lively there. I mean, like it was a complete amalgamation of all the preclinical subjects into one concept, that the importance of physical activity, and even right from the proved facts till the new facts. That is like we had a speaker who was talking about the epigenetics and how the physical activity changes the epigenetics, the gene. And the importance of physical activity, that everything was like conveyed, and the scientific sessions were planned so well that the complete message goes to the public. And also, sir, like the poster presentation and oral presentations were so well planned and organized that never we faced a glitch, even the online, because I can understand that organizing a hybrid conference is very difficult than going for an offline conference these days. So thank you, sir. Thank you so much for the overall, the conference was a big academic fest for all of us. Thank you, sir.
Thank you, Dr. Thank you, Dr. Aisha. Yeah. So with this, thank you with all your feedbacks. Thank you, Pat. To all online? Yeah, fine. So thank you all for participating again. I should, now is the time where we announce the winners of e-poster and oral presentation. We had almost some 57 presentations. Out of 57 presentations, one oral and one e-poster presentations have been selected. And the prize winners are, for paper presentation, we have Dr. Bhuvaneshwari, who has won the Best Paper Award. She will be receiving the certificate along with a small token of appreciation. Please, madam, over to the stage. And for e-poster presentation, the winner is Dr. Aisha Juhi. Dr. Aisha Juhi is an online. All the very best, madam.
Thank you, sir. Thank you so much.
Thank you. With this, we are coming to the end of the session. I would like to call the organizing secretary, Dr. Richa Gupta, to give the vote of thanks, please.
Good afternoon. I'm Dr. Richa Gupta, one of the member secretary for the conferences. We had one from each of the departments for coordination among the departments. So on behalf of our organizing chairpersons and all member secretaries, I really want to thank all the resource persons for their wonderful presentations. And actually it was really the connections which were made between the talks that really helped us understand in deep about exercise physiology from fitness to therapy. I also want to thank all the participants for being active in the conference and sustaining it for 3 days. So that itself is kind of appreciation for us that yes, everybody is active and what we are doing is, I think, maybe okay, at least if I be a little humble about it. And then obviously, when it is valedictory function, it is time to say official goodbye to all and take what we got from here and implement it not just in our own personal lives, but also as academicians, we want to maybe do further research on that, then maybe more collaborations. And if anybody is doing any work on that, then we will be very happy to have a fruitful collaboration on that. So that is an official goodbye from us. But also, since it's the end of a very long journey, which is started quite long back with a lot of hard work from all the 3 departments which has been put up. So definitely it's time for celebration also. So with that, I congratulate all the people who had worked so much hard, the people from all the 3 departments, plus the other technical staff, non-technical staff, everybody who has been a backbone, named or unnamed, and made this event a grand success. But obviously, when we talk about success, I personally believe that we should never ever forget about the failures. So yes, that today is the time to celebrate, but still a bit reminder for all of us who had worked so hard that there might be certain low points, because more the number of people, and we know that how tough is the communication and coordination. So let us forget about the negativities and take up what challenges we have faced as further points of improvement, so that when we do it better, when we meet again, we are able to perform much more. So this is the end of that, and every end is, with every end comes a new beginning. So with that, I thank everyone. Yeah, of course. Thank you. I thank sir for reminding me. Our students who had been there for all 3 days. See, we have got such huge claps for you. So thank you for being there. And wonderful job you did, because standing in front of Vice Chancellor and Dean of Faculty, I know that we get nervous, but you were there and you did a good job. So with that, I just invite everyone for high tea outside. So, yeah. Huh? Yeah. So for online participants, the only serving food we had was obviously the academic food. So maybe next time we will meet in person, and we'll have both kinds of enjoyment, obviously. So I thank all the online participants also. So from here, we'll sign off. Thank you so much. Thank you, everyone.